Hi everybody. Am I audible and visible? Good evening. If I'm audible and visible, can I have a thumbs up on the live chat? Good evening, Vishnu. Good evening, Said. Great. So, welcome to FMG LRR session. In this session, I've chosen the last 4 FMG papers, and I've included all MCQs so that we cover most of the topics that are frequently asked about. Okay? Yes. So, let's start. Yes, good evening, everybody. Good evening, Chaitanya. So let's start with the first MCQ here. This was an image-based question, which was asked in FMG Jan 2026, the very latest one. Is it enough for FMG, Kashyap? I'm not here to give you false promises to say that this is enough. But yes, listening to this session will cover at least 80% of MCQs that are asked in the, that can be expected in the upcoming FMG exam. So use this as a base and then watch all recall sessions of FMG. Okay, watch image-based question that is on the YouTube, and that should cover most of the MCQs. Yeah. So let's start. So a patient presents with photosensitivity, purpura, blistering skin lesions on sun-exposed area. Biochemical evaluation shows a defect in the conversion of uroporphyrinogen 3 to coproporphyrinogen 3 in heme synthesis pathway. So which enzyme is deficient? Okay. No, this is not a 5-hour session. Who said this is going to be a 5-hour session, Pratik? I will close this session in 3 hours. Okay. So they have told you that it is a defect in the conversion of uroporphyrinogen to coproporphyrinogen. And what you see is only photosensitivity. They have not given you any neuropsychiatric manifestations. Okay, only photosensitivity, no neuropsychiatric manifestations. The answer is uroporphyrinogen decarboxylase defect. And decarboxylase defect has got a C. Okay, and the condition is called as a C. What does C mean? Porphyria cutanea tarda. Okay, uroporphyrinogen decarboxylase defect is called as porphyria cutanea tarda. Cutanea meaning there are only photosensitivity manifestations, no neuropsychiatric manifestations. So what are we going to do today? Great lab 2, but feeling scared of biochemistry because scoring. Okay, let's first watch this session and we can take up all your doubts later on. Okay, so watch this session. So what I'm going to show you now is I'm going to show you heme synthetic pathway. We are going to learn about the names of these disorders first, and then you're going to classify porphyrias into 3 categories. Okay, that is the aim today. So what happens when the first enzyme ALA synthase is defective? When ALA synthase is defective, this is a complete defect, which means the final product heme cannot be synthesized. If heme is not synthesized, you would call it as anemia. So only ALA synthase defect is called as anemia. You have an adjective to it. So this is X-linked sideroblastic anemia. Yeah, what is this condition called as? Called as X-linked sideroblastic anemia. So repeat this along with me. Whenever ALA synthase 2 is defective, that causes anemia because it's a complete defect. Heme cannot be synthesized, causing anemia. Which anemia is it? This is called as X-linked sideroblastic anemia. Okay. Now, what if ALA dehydratase is defective? When ALA dehydratase is defective, logically, what would you call it as? You would call it as ALA dehydratase defective porphyria. Can you repeat this? What is that condition called as? ALA dehydratase defective porphyria. When the next enzyme, uroporphyrinogen 1 synthase is defective. This is the most popular acute intermittent porphyria. Okay, uroporphyrinogen 1. In 1, you see Roman letter 1, right? Roman letter 1 is alphabet I. The condition is an I, acute intermittent porphyria. So, acute intermittent porphyria is caused by the defect of uroporphyrinogen 1 synthase. Okay. Then uroporphyrinogen 3 synthase is defective. 3 and E sound similar, right? 3 and E sound similar. I will ask you this in another few questions. Okay. So 3 and E sound similar. 3 synthase defect causes E. What is this E? Congenital erythropoietic porphyria. E stands for congenital erythropoietic porphyria, and this is the vampire disease. So I'm sure all of you know about vampires. Vampires are described as having nocturnal behavior. Vampires are described as drinking blood. Right, all these because of congenital erythropoietic porphyria. The first time an author wrote about vampire must have seen a patient of congenital erythropoietic porphyria. This patient, for fear of photosensitivity, would have come out only during the night. That is why vampires are described as having nocturnal behavior. Okay, when porphyrins accumulate in teeth, that gives red fluorescence of teeth. This red fluorescence of teeth is called as erythrodontia. That erythrodontia was mistook by the author as the patient having the habit of drinking blood. So vampire disease is congenital erythropoietic porphyria. This is the most severe of all photosensitivity porphyrias. Do you understand this? So that is caused by the defect of uroporphyrinogen 3 synthase defect. When uroporphyrinogen decarboxylase is defective, there is nothing for you to be scared of biochemistry, nothing for you to be scared of PSM. This is not the time for you to get anxious. Okay, so focus on what is being discussed. Get out of that anxiety mode. Yeah, be in a relaxed. When I say relax, I'm not saying be cool. Don't listen to this. Okay, I want you to be focused. I don't want you to be anxious at this point in time. So use your 3 hours. Use the remaining 3 hours of your time today and learn as much as possible in biochemistry. That will form a strong foundation based on which you can build more. Okay, so listen to this. Whenever uroporphyrinogen decarboxylase, do you see that this is the enzyme which converts uroporphyrinogen to coproporphyrinogen? So decarboxylase has got a C. The defect has got a C. What does C stand for? Porphyria cutanea tarda. Okay, so uroporphyrinogen decarboxylase defect causes porphyria cutanea tarda. Coproporphyrinogen oxidase defect. Can you give a logical name to it? Coproporphyrinogen oxidase defect causes accumulation of coproporphyrinogen. So this condition is called as hereditary coproporphyria. Okay, coproporphyrinogen oxidase defect is called as hereditary coproporphyria. Protoporphyrinogen oxidase. I am shortly writing protoporphyrinogen oxidase as double PO. So in the name, do you see various P's? Right? You see various P's. Defect causes variegate porphyria. Do you understand this? Defect causes variegate porphyria. When the last enzyme ferrochelatase is defective. When ferrochelatase is defective, protoporphyrin accumulates. So you call this condition as erythropoietic protoporphyria. Okay, when ferrochelatase is defective, protoporphyrin accumulates. So you call this condition as erythropoietic protoporphyria. So what are we going to do now? We are going to repeat this because there is no shortcut to memory. It is just repetition. So during the session, along with me, you're going to memorize all facts. You're going to revise all facts every now and then. Okay. So let's revise that quickly. All of you tell me what happens when ALA synthase 2 is defective. When ALA synthase 2 is defective, it's a complete defect that causes anemia. Which anemia is it? That is called as X-linked sideroblastic anemia. Okay. When ALA dehydratase is defective, what is that condition it called as? ALA dehydratase defective porphyria. Okay, ALA dehydratase defective porphyria. When uroporphyrinogen 1 synthase is defective, how did I ask you to remember this? 1, Roman letter 1 is like the alphabet I. So that causes I. What does this I stand for? Acute intermittent porphyria. Uroporphyrinogen 1 synthase defect causes acute intermittent porphyria. Whereas uroporphyrinogen 3 synthase, 3 and E sound similar. Want to thank you sincerely. You passed your FMGE Jan 2026 LR 151. So happy for you, Joel. So happy. My best wishes. Congratulations. Yeah. So uroporphyrinogen, I'm very happy to know that my session contributed in your success. This made my day. So uroporphyrinogen 3 synthase defect, 3 and E sound similar. It causes congenital erythropoietic porphyria. Okay. Then uroporphyrinogen decarboxylase is defective. Decarboxylase has got a C and the condition is called as a C. What does the C stand for here? Porphyria cutanea tarda. Okay. When coproporphyrinogen oxidase is defective, what do you call that condition as? Hereditary coproporphyria. When protoporphyrinogen oxidase is defective, you see various P's. So the condition is called as variegate porphyria. The last one is ferrochelatase defect. When ferrochelatase is defective, you call it as erythropoietic protoporphyria. Okay. Now, how do we classify porphyrias? You classify porphyrias into 3 categories. The first category presents with neuropsychiatric manifestations. Please look at this. Yeah, this is how you classify porphyrias into 3 categories. The first category presents with neuropsychiatric manifestations. The second category presents with photosensitivity. The third category presents with both neuropsychiatric manifestations and photosensitivity. So what do I mean by neuropsychiatric manifestations? Neuro means aberrant pain. Yeah, what do they present with? Because of the peripheral sensory neuropathy, they present with aberrant pain, which is complaint of, the patient complains of abdominal pain, recurrent abdominal pain. So initially sensory nerves are affected, then motor nerves get affected and even autonomic nerves get affected. That is why it is neuro. Okay, psychiatric because these children present with cyclical bizarre behavior. So whenever you see these 2 manifestations, acute abdominal pain, peripheral sensory neuropathy, and the child presents with bizarre behavior, repetitive cyclical bizarre behavior, it is neuropsychiatric manifestations. What do you mean by photosensitivity? In this case, the patient would say, whenever I go out in sunlight, I first feel itching. This itching is followed by burning sensation. Then I see blisters. Blisters are followed by atrophic scars. Okay. And then when you observe, you see hypertrichosis. You see erythrodontia. So if these features are described, then your patient is presenting with photosensitivity. Sometimes your patient presents with both neuropsychiatric manifestations and photosensitivity. Okay. Now, what if there is only neuropsychiatric manifestations? The first 2 disorders. What are the first 2 disorders? ALA dehydratase defective porphyria and acute intermittent porphyria. Repeat this. If there is only neuropsychiatric manifestations, it is ALA dehydratase defective porphyria and acute intermittent porphyria. If there is only photosensitivity, I told you the most severe of all photosensitivity porphyrias is congenital erythropoietic porphyria. The most common is porphyria cutanea tarda. Cutanea tells you that it is only photosensitivity. So porphyria cutanea tarda. The last one, which is the last one? Erythropoietic protoporphyria. So what are the 3 porphyrias which present with only photosensitivity? The vampire disease, which is congenital erythropoietic porphyria, porphyria cutanea tarda, and erythropoietic protoporphyria. What if you see both, right? Both are seen in hereditary coproporphyria. How can you remember this? Copro. Copro has got co. What do you mean by co? Both. Simultaneous. So what is simultaneously seen? You see both photosensitivity and neuropsychiatric manifestations. So it is hereditary coproporphyria and the other one is variegate porphyria. How can you remember? Variegate also presents with both. Variegate is various manifestations in the form of both neuropsychiatric manifestations and photosensitivity. Yeah, can we repeat this, all of you? Simple way. Thanks everybody. Thank you. So can we repeat this? What are the porphyrias which present with neuropsychiatric manifestations, all of you? The first one is ALA, dehydratase defective porphyria. The second one is acute, hi Nikita. The second one is acute intermittent porphyria. Okay. What are the porphyrias which present with only photosensitivity? The vampire disease, which is congenital erythropoietic porphyria, Porphyria cutanea tarda. The last one, erythropoietic protoporphyria. Where do you see both? One is hereditary coproporphyria. The other one is variegate porphyria. Do you get it? So apart from this, as far as heme synthesis and porphyrias are concerned, they also ask you about lead poisoning. In FMG, I've seen MCQs on lead poisoning. So lead inhibits, okay, lead inhibits 3 enzymes of heme synthesis. The first enzyme is ALA dehydratase. Okay, it inhibits ALA dehydratase. Second is it inhibits coproporphyrinogen oxidase. The third one is the last enzyme ferrochelatase. This can be asked as a one-liner. Tell me, lead inhibits how many enzymes? It inhibits 3 enzymes of heme synthesis. It inhibits ALA dehydratase. It inhibits coproporphyrinogen oxidase and it inhibits ferrochelatase. Okay, so these are the 3 enzymes inhibited by lead poisoning. Accordingly, what will you see as biochemical features? Biochemical features would be elevation of ALA, elevation of coproporphyrinogen, and when ferrochelatase is inhibited, zinc protoporphyrins are elevated. Okay, zinc protoporphyrins are elevated. So tell me, what are the biochemical features of lead poisoning? In lead poisoning, ALA is elevated. This ALA causes neuropsychiatric manifestations. Do you understand this? Elevation of ALA causes neuropsychiatric manifestations. So they present with acute abdominal pain and cyclical bizarre behavior. Because coproporphyrinogen is inhibited, coproporphyrinogen levels are elevated. Because ferrochelatase is inhibited, zinc protoporphyrin levels are high. And you see sideroblasts in this condition. Okay, so that is about lead poisoning. Good. So now the answer is clear, right? What you see here is just photosensitivity, and biochemical evaluation shows an inhibition of conversion of uroporphyrinogen to coproporphyrinogen. So it is uroporphyrinogen decarboxylase defect. Okay, so the right answer is choice B. Okay. A child presents with bruising, with EC bruising and bleeding. Physical examination reveals multiple ecchymosis and purpuric lesions over the body as shown in the image. Heme arthrosis is absent. So this is something which you should remember. Whenever they say heme arthrosis is absent, it means there is no deep bleeding. If you see deeper bleeding, it could be vitamin K deficiency, clotting pathway getting affected. In that case, you would see heme arthrosis. Whenever they say heme arthrosis is absent, it means you can exclude vitamin K deficiency. All that you see is only superficial bleeding. So whenever you see superficial bleeding, that is capillary fragility. Capillary fragility is caused by vitamin C deficiency. So EC, bruising and bleeding without heme arthrosis. If there is heme arthrosis, you should suspect clotting pathway defect, which could be vitamin K deficiency. In this case, it's only superficial bleeding, which means what is it? It is fragility of capillaries. When do you see fragility of capillaries? Whenever there is vitamin C deficiency. Why? Because vitamin C is necessary for collagen maturation. Please remember, what is vitamin C necessary for? Collagen maturation. Why is it necessary for collagen maturation? Because vitamin C is necessary for prolyl hydroxylase. Please memorize all these facts. I am giving you only high yield facts. Okay. Because vitamin C is necessary for prolyl hydroxylase and lysyl hydroxylase, both of which are involved in collagen maturation. So whenever there is vitamin C deficiency, collagen cross linkages do not get established. So capillaries are fragile and that causes superficial bleeding. So what is the right answer, all of you? The right answer here is vitamin C. You should remember C for collagen maturation because it's necessary for prolyl hydroxylase and lysyl hydroxylase. Okay. So similar to this, there was another question in FMG. Look at this, Jan 2025. So 2026 and in 2025, a similar question. A patient presents with gum bleeding, petechiae, poor wound healing and other related symptoms. Which of the following vitamin deficiencies is most likely responsible for this presentation? Again, what is the right answer? The right answer is vitamin C. Okay. Now, in line with this, another previous year question asked in FMG Jan 2025. Which of the following enzymes is dependent on vitamin C for its activity? What is the right answer, everybody? Vitamin C is necessary for prolyl hydroxylase and lysyl hydroxylase. What is the right answer? I'm seeing some answers as B. That is why I chose this MCQ to be discussed. So it is prolyl hydroxylase and lysyl hydroxylase which is dependent on vitamin C. For those of you who chose it as choice B, lysyl oxidase is dependent on copper. Yeah, lysyl oxidase is dependent on copper. This is also necessary for collagen maturation. So whenever they ask you what are the micronutrients necessary for collagen maturation, what will be your answer? One is vitamin C, the other one is copper. No confusion here. Vitamin C is necessary for prolyl hydroxylase and lysyl hydroxylase. Copper is necessary for lysyl oxidase. Okay, copper is necessary for lysyl oxidase. Okay. Very rarely genetics MCQs are asked in FMG. This was asked in Jan 2026. DNA matching used for identification and comparison among family members is based on analysis of which genetic marker? So this is DNA fingerprinting. DNA fingerprinting is done by BNTR analysis. Very good. Yes, I see many of you answering it right. That gives me extreme happiness. Great. So it is BNTR analysis. What is BNTR analysis? Variable number of tandem repeat. Okay, variable number of tandem repeat analysis or short tandem repeats. So the answer for this question is choice A. Okay. Let me tell you few facts about satellite DNA and about DNA fingerprinting, because as you see before, there had been a pattern in which questions are asked. They always stick to the topic. They make minimal changes in the question. So they might ask you some other question based on this topic. Let's try to learn about this. Okay. So I'm going to tell you about DNA fingerprinting. DNA fingerprinting is person identification, right? DNA fingerprinting is person identification by utilizing uniqueness of genetic sequences. Which sequences do you use for this purpose? Satellite DNA, right? For DNA fingerprinting, for identifying a person, which sequence do we use? We use satellite DNA. Satellite DNA has two other names. One is highly repetitive sequences. The other one is simple segment repeats. So tell me, what are the other two names for satellite DNA? Satellite DNA is also called as highly repetitive sequences or simple segment repeats. Why are they called as highly repetitive sequences? Because they are repeated more than lakh times. In your entire genome, if you count the number of times they are repeated more than lakh times. Okay, that's why they're called as highly repetitive sequences. Why are they called as simple segment repeats? Because they are completely non-coding. They code for nothing. They are simple segments which are just repeated. Okay, that is why they are called as simple segment repeats. Now, there are two types of satellite DNA based on the length. One is microsatellite, the other one is mini satellite. So what are the two types? Microsatellite repeat and mini satellite repeat. The other name for mini satellite repeat is variable number of tandem repeat. I am writing the full name. What is it called as? Variable number of tandem repeats. And this is what is being used for person identification. It has got forensic application. It can be used to clear of paternal dispute cases. What do you mean by paternal dispute cases? Suppose there is a mother. This mother has a child. And this mother claims person X as the father. Do you understand this? There is a mother with a child. This mother claims person X as the father. And you are asked to find out if X could be the father of this child. This is what we mean by solving paternal dispute cases. For which, what do you use? You use variable number of tandem repeat analysis. Okay. So for any molecular diagnostic test, okay, for any molecular diagnostic test, step number 1 is sample collection. So what do? You collect blood sample from the mother, the child and the suspected father. Right? What is step number 1? Step number 1 is sample collection. In this case, you have collected blood sample from the mother, the child and the suspected father. Step number 2 is from the sample you extract DNA. So how many DNA samples do we have? 3 DNA samples, one of the mother, one of the child, one of the suspected father. In all the 3 DNA samples, you will have to analyze the inheritance of at least 5 microsatellite repeats at 5 loci each. In all the 3 DNA samples, you will have to analyze the inheritance of at least 5 microsatellite repeats at 5 loci each. For example, CAG repeat, CTG repeat, CGG repeat, GAA repeat. Likewise, you should choose 5 repeats at 5 loci. So totally 25 loci will be checked in all the 3 DNA samples. For one particular repeat, I'm going to just give you an example. For one particular repeat, say CAG repeat at one locus, at some locus, okay, at some locus, you are checking the child's DNA. Suppose the child's DNA shows 8/8 repeats. What do you see in the child's DNA? The child's DNA, you see 8/8 repeats. If you're all wondering, why am I giving 2 numbers? Whenever I specify a location, that location will be there in both the chromosomes. We have 2 copies of all chromosomes. So whenever you specify location, that location is expected in both the chromosomes. So when I say 8/8, it means in the child, this satellite DNA is repeated 8 times in one chromosome, 8 times in the other chromosome. One has come from the father, the other one has come from the mother. Okay, the same repeat, same locus, check in the mother's DNA how many times it's repeated. Suppose in the mother's DNA it is 11/8. What do you see in the mother's DNA? In the mother's DNA it is 12/8. Okay, so what is your inference? Your inference is one of the 8s of the child has come from the mother. Right? What is your inference? Your inference is one of the 8s of the child has come from the mother. So it is imperative that the other 8 comes from the father. If one has come from the mother, the other one should come from the father. So the same repeat, same locus, check the father's DNA. See how many times it's repeated. Suppose it's repeated something other than 8. Suppose the father's DNA shows 12/10 or 13/15. Then what is your conclusion? If it's something other than 8, then your conclusion is this person cannot be the biological father of the child. Do you understand this? This person cannot be the biological father of the child. Okay, so this is how DNA fingerprinting is done. So whenever they ask you about DNA fingerprinting, always think of satellite DNA. 2 types of satellite DNA, microsatellite repeats and mini satellite repeats. The other name for mini satellite repeat is variable number of tandem repeat. Okay, so for solving paternal dispute cases, we use only satellite DNA or tandem repeat analysis. So what is the right answer, everybody? The right answer here is short tandem repeats. Okay. Eruptive xanthomas with a prominent chylomicron band on lipid electrophoresis are most commonly seen due to. This is also an FMGE Jan 2026 MCQ. So there were many case-based MCQs in the latest exam. One is this. Okay. Whenever you see answer, let me tell you the answer first. The answer is choice B. Good, Suhail. Yeah, answer is choice B. Okay. But let me help you understand this question. If you see eruptive xanthomas, eruptive xanthoma is a sign of hypertriglyceridemia. Okay, whenever you see eruptive xanthoma, it's a sign of hypertriglyceridemia. Prominent chylomicron band means it is chylomicronemia syndrome. Prominent chylomicron band is chylomicronemia syndrome. So what is this? This is familial chylomicronemia syndrome, okay, caused by the defect of ApoC2 or lipoprotein lipase. It is caused by the defect of ApoC2 or lipoprotein lipase. So for now, just understand that the answer is choice B, lipoprotein lipase deficiency, because lipoprotein lipase is involved in metabolizing chylomicron. When that enzyme is defective, chylomicrons accumulate in the blood. Chylomicron carries triacylglycerol. So in this condition, triglyceride levels are high. Whenever there is hypertriglyceridemia, you see eruptive xanthomas. Okay. So for now, the answer is choice B. But what are we going to do now? My request to those who are watching this session to stay back for the next 10 minutes, right? So what are we going to do in the next 10 minutes? We are going to learn all about hyperlipoproteinemias, because not just this MCQ, there were many MCQs. There have been many MCQs that they have asked in hyperlipoproteinemia. So we are going to learn all about hyperlipoproteinemia in the next 10 minutes. Watch this carefully. Okay, so hyperlipoproteinemias, it's all about Frederickson's classification. Frederickson classified hyperlipoproteinemias into 6 types. Please remember how many types? 6 types. Type 1, type 2A, type 2B, 3, 4 and 5. So tell me, what are the 6 types? Type 1, 2A, 2B, 3, 4 and 5. But what are we going to do? We are going to classify these 6 types into 3 categories. The first category presents with only an elevation of cholesterol. The second category presents with only an elevation of triacylglycerol. The third category presents with an elevation of both. Do you understand this? So what are the 3 categories? The first category presents with an elevation of only cholesterol. Second category, elevation of only triglyceride. In the third category, there is an elevation of both cholesterol and triglyceride. Okay, because presentation will differ based on this. Whenever there is an elevation of cholesterol, they present with tendon xanthomas. Yes, this topic is very important. I'm going to explain. So all of you, I want you to come out of this FOMO mode. I will explain every choice if you give me some time. Okay, so you don't have to be in a hurry typing all this on the chat box, right? So what are you supposed to do now? Be mindful. This is the time when you have to be mindful. You should be listening to whatever I'm saying. Okay, so tell me what happens whenever cholesterol level is high. Whenever cholesterol level is high, they present with tendon xanthomas. They present with accelerated atherosclerosis. So all of you repeat this. What are the manifestations of hypercholesterolemia? They present with tendon xanthomas and accelerated atherosclerosis. So what are tendon xanthomas? Do you see that in the image? Right, you see that in the image. So what are tendon xanthomas? These are small eruptive lesions which are present along the line of attachment of tendons. Where are tendons more pronounced? Along the knuckles or along the ankles. So do you see that here? These are tendon xanthomas. If you see tendon xanthomas, that's a sign of hypercholesterolemia. They can present with accelerated atherosclerosis. Whereas if your patient has elevated triglyceride, they don't present with tendon xanthomas, they actually present with eruptive xanthomas. Both are different. They present with eruptive xanthomas. They don't present with accelerated atherosclerosis. They present with recurrent pancreatitis. And on examination, you would find lipemia retinalis. So all of you repeat this. What are the manifestations of elevation of triglyceride? Whenever triglyceride is elevated, they present with eruptive xanthomas, recurrent pancreatitis. On examination, you find lipemia retinalis. So look at this. These are eruptive xanthomas. So what are eruptive xanthomas? These are even tinier than tendon xanthomas, and they are present along the extensor surfaces of the limb. Okay, so don't get confused between eruptive xanthomas and phrenoderma. Right, phrenoderma is a sign of vitamin A deficiency. These are also present along the back of elbow, but if it's phrenoderma, you see small eruptive lesions with keratin plug at the tip. Right, if you see keratin plug at the tip, then that is phrenoderma, vitamin A deficiency. That is different. This is eruptive xanthoma, which is sign of elevation of triacylglycerol. Okay. Whereas if your patient has got an elevation of both cholesterol and triglyceride, then you see a mix of both these features. They present with both tendon xanthomas and eruptive xanthomas. They present with accelerated atherosclerosis. They present with recurrent pancreatitis. If you see all these together, that's the third category. Okay. Now we have classified it. We have 6 types. Out of the 6 types, only one type fits into the first category, wherein cholesterol alone is elevated. Cholesterol alone is elevated in type 2A. Okay, cholesterol alone is elevated in type 2A hyperlipoproteinemia. Because in type 2A only cholesterol is elevated, logically what will you call it as? Please tell me. You will call it as familial hypercholesterolemia. So what is type 2A? Type 2A is familial hypercholesterolemia. It is caused by the defect of LDL receptor. Do you understand this? It's caused by a defect of LDL receptor or ApoB100. LDL receptor or ApoB100. So you should ask me why. Because of the function of LDL receptor. Where are LDL receptors present? LDL receptors are present in extrahepatic tissues and they are present in the liver. Do you understand this? LDL receptors are present in extrahepatic tissues and they are present in the liver, wherein their function is to accept. What is their function? Their function is to accept any lipoprotein which has ApoB100. Any lipoprotein which has ApoB100. And the major lipoprotein which has ApoB100 is LDL. Do you understand this? So this is the function of LDL receptor. Now think logically and tell me what would happen whenever there is a defect of LDL receptor or of ApoB100. In either case, LDL will not be cleared off from the circulation. LDL stays back in the circulation. LDL carries cholesterol. Carrying cholesterol, if LDL accumulates in the circulation, cholesterol level will be elevated. Hence the name familial hypercholesterolemia. Do you all understand this? So tell me, which is the only hyperlipoproteinemia wherein cholesterol alone is elevated? Type 2A. That is why type 2A is otherwise called as familial hypercholesterolemia. It is caused by the defect of LDL receptor or ApoB100. And it is an autosomal dominant condition. Do you understand this? It's an autosomal dominant condition. So that is about the first category. Second category, wherein triglyceride alone is elevated. Triglyceride alone is elevated in type 1, type 4 and type 5. Okay, type 1, type 4 and type 5, only triglyceride is elevated. About 4 and 5. 4 and 5 are caused by one common genetic defect. Do you understand this? 4 and 5 are caused by one common genetic defect. So whenever you include 4, you can include 5 also in the list. Okay, and then how to remember this list? Triglyceridemia. Tri is 3, right? Tri is 3. 1 plus 3 is 4, right? Tri is 3. 1 plus 3 is 4. So 1, 4 and 5, hypertriglyceridemia. Now tell me, what are the conditions wherein both cholesterol and triglycerides are elevated? Both are elevated in the remaining conditions. What is remaining? Type 2B and 3. In type 2B and 3, both cholesterol and triglyceride are elevated. So I want everybody who's here, right? Everybody who's watching here to keep the live chat active. So tell me, what are the 3 categories? Only cholesterol is elevated, only triglyceride is elevated, both are elevated. Only cholesterol is elevated in which type? Type 2A. Only triglyceride is elevated in 1, 4 and 5, right? Both are elevated in 2B and 3. Are you clear? So this is about classification. Now about type 1 hyperlipoproteinemia. We are done with type 2A. I am going to tell you about type 1 hyperlipoproteinemia. Whenever you learn any lipoprotein, right? Whenever you learn lipoprotein metabolism or any topic in lipoprotein, first you will be taught chylomicron. We always start with chylomicron. So type 1 is also related to chylomicron. It is called as familial chylomicronemia syndrome. So tell me, what is type 1? Type 1 is familial chylomicronemia syndrome, and it is caused by the defect of ApoC2 or lipoprotein lipase. It is caused by the defect of ApoC2 or lipoprotein lipase. Let me tell you why. Okay, for understanding this, you need to know what does chylomicron do. Just listen to this for 30 seconds. Okay, just 30 seconds of your attention. What does chylomicron do? Chylomicron transports exogenous or dietary triacylglycerol. Right? Chylomicron transports exogenous or dietary triacylglycerol from intestine to extrahepatic tissues. Do you understand this? Can you repeat this? Chylomicron transports exogenous or dietary triacylglycerol from intestine to extrahepatic tissues. When this chylomicron is formed, this chylomicron has few apoproteins. One is, it has ApoB48. I said ApoB100 is in LDL. ApoB48 is in chylomicron. So it has ApoB48, ApoC2 and ApoE. Chylomicron has got ApoB48, ApoC2 and ApoE. What is the function of ApoC2? ApoC2 activates lipoprotein lipase. Okay, ApoC2 activates lipoprotein lipase, which is an enzyme which is clinging to the vessel wall. This enzyme is clinging to the vessel wall, that gets activated by ApoC2. Now, what does lipoprotein lipase do? Lipase always acts on triacylglycerol. So, lipoprotein lipase acts on chylomicron's triacylglycerol. Okay, lipoprotein lipase acts on chylomicron's triacylglycerol, cleaves it to give glycerol and fatty acid. Okay, cleaves it to give glycerol and fatty acid. After which this fatty acid enters into extrahepatic tissues where it is stored as triacylglycerol. Okay, after chylomicron has lost its triacylglycerol this way, chylomicron becomes chylomicron remnant. After chylomicron has lost its triacylglycerol, chylomicron becomes chylomicron remnant. Any remnant reaches the liver. Do you understand this? It can be chylomicron remnant, it can be VLDL remnant, that is immaterial. All these remnants reach the liver. This is how chylomicron metabolism is completed. Do you understand this? So chylomicron is formed in the intestine, released into the circulation. This chylomicron is ApoB48, ApoC2 and ApoE. ApoC2 activates lipoprotein lipase. Then lipoprotein lipase initiates chylomicron's metabolism. Lipoprotein lipase acts on chylomicron's triacylglycerol, cleaves it to give glycerol and fatty acid. That is how chylomicron's metabolism happens. Then chylomicron becomes chylomicron remnant. It reaches the liver. Now tell me what happens whenever there is a defect of ApoC2 or whenever there is a defect of lipoprotein lipase. ApoC2 defect or lipoprotein lipase defect, chylomicron will not be metabolized. So chylomicron stays back in the circulation. Chylomicron carrying triacyl glycerol is staying back in the circulation. That causes massive hypertriglyceridemia. Do you understand this? This causes massive hypertriglyceridemia. I hope you all know that normal triglyceride level is less than 150 milligram per deciliter. In this case, triglyceride level can be as high as 1500 milligram per deciliter and above. So massive hypertriglyceridemia. What will the patient present with? As I told you, the patient would present with eruptive xanthomas, recurrent pancreatitis. On examination, you find lipemia retinalis, right? On examination, you find lipemia retinalis. To prove that this is the diagnosis, to prove that this is a case of familial chylomicronemia syndrome, you should show that this person's lipoprotein lipase activity is low. To prove that this is the diagnosis, what should you show? You should show that plasma lipoprotein lipase enzyme activity is low. That is all about type 1 hyperlipoproteinemia or familial chylomicronemia syndrome. Yes, break time for me. It can also be because of ApoB100, LDL receptor or ApoB100. Okay. So this was the question, right? The question said the patient presents with what? Eruptive xanthomas. Chylomicron band was seen on lipoprotein electrophoresis. Then what is your diagnosis? Your diagnosis is familial chylomicronemia syndrome, which is caused by the defect of ApoC2 or lipoprotein lipase. Okay. Now about type 3. Type 3 hyperlipoproteinemia. Just 15 minutes back, I said 3 and E sound similar. Did I tell you? Just 15 minutes back, I said 3 and E sound similar. So type 3 hyperlipoproteinemia is ApoE defect. When did I say 3 and E sound similar? Can anybody recollect? I said uroporphyrinogen 3 synthase defect causes congenital erythropoietic porphyria. Yeah, 3 and E. Even here, 3 and E. Type 3 is ApoE defect. ApoE is an apoprotein of remnants. ApoE is an apoprotein of remnants. So in this condition, remnants will not be cleared off from the circulation. Remnants accumulate in the circulation. So we call it as a remnant disease. Remnants carry both cholesterol and triglyceride. LDL carries what? Cholesterol. Chylomicron and VLDL. Chylomicron and VLDL carry triglyceride. Remnants carry both cholesterol and triglyceride. Do you understand this? Remnants carry both cholesterol and triglyceride. So this is about what happens in these conditions. So in remnant disease, when remnants accumulate, both cholesterol and triglyceride accumulate. So this is a mixed hyperlipidemia. Do you understand this? I said only type 2B and type 3, both cholesterol and triglyceride are elevated. So in this condition, there is an elevation of both cholesterol and triglyceride. On lipoprotein electrophoresis in type 3 hyperlipoproteinemia, you see a broad beta band, right? You see a broad beta band. So you call this condition as broad beta disease. Okay. And this is also called as familial dysbeta lipoproteinemia. Broad beta disease is also called as familial dysbeta lipoproteinemia. And there are two pathognomonic features of type 3. Look at this. Palmar eruptive xanthomas. Eruptive xanthomas can be present anywhere. But if you see eruptive xanthomas in the palm, right? Palmar eruptive xanthoma is a sign of type 3 hyperlipoproteinemia. The other one is xanthoma palmaris striae. Whenever you see yellowish discoloration of palmar creases, right? Yellowish discoloration of palmar creases, that is called as xanthoma palmaris striae. These two are pathognomonic for type 3 hyperlipoproteinemia. So all of you repeat about type 3 hyperlipoproteinemia. 3 and E sound similar. 3 is ApoE defect. ApoE is an apoprotein of remnants. In this condition, remnants accumulate. So it's called as remnant disease. Remnants carry both cholesterol and triglyceride. So in this condition, both the lipids are elevated. Okay, and on lipoprotein electrophoresis, you see a broad beta band. So it's called as broad beta disease or familial dysbeta lipoproteinemia. 3 names for type 3, right? What are the 3 names for type 3? One is remnant disease. Second is broad beta disease. Third is familial dysbeta lipoproteinemia. There are 2 pathognomonic features for type 3. One is palmar eruptive xanthomas. The other one is xanthoma palmaris striae. Okay. Now about type 4 and type 5. Okay. I said type 4 and type 5 are caused by a common genetic defect. So 4 and 5 triglycerides are elevated. 4 and 5 triglycerides are elevated. So 4 and 5 are collectively called as familial hypertriglyceridemias. They are collectively called as familial hypertriglyceridemias. Both these are caused by a common genetic defect which is not known. But that genetic defect is supposed to cause, is found to cause an increase in the rate of VLDL synthesis and decrease in the rate of VLDL breakdown. Do you understand this? Both type 4 and type 5 are caused by a common genetic defect which causes an increase in the rate of VLDL synthesis and decrease in the rate of VLDL breakdown. So in both the conditions, VLDL levels are high. If there is only a primary genetic defect, that's called as type 4. If there is only the primary genetic defect, it's called as type 4. But if a type 4 individual has an accompanying secondary reason for hypertriglyceridemia, a type 4 individual who has a superimposed secondary reason for hypertriglyceridemia, for example, type 4 who is obese, okay, another reason for hypertriglyceridemia, or a type 4 individual who is an alcoholic, further increase in triglyceride, or a type 4 individual who's on oral contraceptive pills, type 4 with nephrotic syndrome. So in all these conditions, there is a superimposed reason which causes another, which is another reason for hypertriglyceridemia. So there is massive hypertriglyceridemia, in which case you call it as type 5. So in type 4, only VLDL levels are high. Whereas in type 5, both VLDL and chylomicron levels are high. Okay, so for your understanding, I am repeating about type 4 and type 5. This was asked in FMGE. Okay, so type 4 and type 5 are collectively called as familial hypertriglyceridemias. Both are caused by a common genetic defect which causes an increase in the rate of VLDL synthesis and decrease in the rate of VLDL breakdown. Put together in both these conditions, VLDL levels are high. If there is only the primary genetic defects called as type 4, if a type 4 individual has an associated secondary reason for hypertriglyceridemia, that's called as type 5. So in type 4, only VLDL levels are high. In type 5, both chylomicron and VLDL levels are high. That is why type 5 is called as familial mixed, right? It's called as familial mixed hypertriglyceridemia. Type 5 is called as familial mixed hypertriglyceridemia. So that is all about hyperlipoproteinemias. I am going to give you a very short summary of hyperlipoproteinemia. All of you listen to this. How many types? 6 types. Type 1, 2A, 2B, 3, 4 and 5, totally 6 types. And we classify these 6 types into 3 categories. The first category, only an elevation of cholesterol, type 2A. Only an elevation of triglyceride, 1, 4 and 5. Both are elevated in 2B and 3. In type 1, familial chylomicronemia syndrome caused by the defect of ApoC2, or lipoprotein lipase. Type 2A, only cholesterol is elevated, a defect of either ApoB100 or LDL receptor, right? ApoB100 or LDL receptor. Type 3, 3 and E sound similar. 3 is an ApoE defect. Broad beta disease, remnant disease, familial dysbeta lipoproteinemia. Like in the MCQ, if they had given you on lipoprotein electrophoresis, a broad beta band was seen, then what should have been your diagnosis? In that case, it is type 3, caused by ApoE defect. Okay. In type 3, you see palmar eruptive xanthomas and xanthoma palmaris striae. Type 4 and type 5, familial hypertriglyceridemias. If the question says only VLDL is elevated, it is type 4. If the question says both chylomicron and VLDL are elevated, then it is type 5. Type 5 is called as familial mixed hypertriglyceridemia. Are you all clear? Yeah. So tell me, what is the right answer? Eruptive xanthomas, right? Eruptive xanthoma is hypertriglyceridemia with a prominent chylomicron band. So what is the condition? The condition is type 1. What is type 1 due to? Please answer. Type 1 is because of the defect of either lipoprotein lipase or ApoC2. Okay. Can you tell me about other choices? This is what everybody wanted, right? Now tell me the answer. LDL receptor defect is called as type 2A. ApoB100 defect is also type 2A. ApoE deficiency, what is it? Type 3. Okay, good. See, this is what I told you, FMG July 2025. Okay, a man presents with high VLDL and chylomicron. I have not seen such MCQs in NEET PG or an INI-CET. It's as complex as this. Okay, elevation of VLDL and chylomicron. With eruptive xanthomas, what is the most likely diagnosis, all of you? The most likely diagnosis is familial mixed hypertriglyceridemia. Good. A patient presents with ataxia. This is again FMG Jan 2026. A patient presents with ataxia, ichthyosis, retinitis pigmentosa, and cardiac conduction defects. Okay, the clue, the major clue that is given to you is lab evaluation reveals increased phytanic acid. Okay, so there are two clues that I want you to take up. One is retinitis pigmentosa, the other one is phytanic acid accumulation. So that is Refsum's disease. Do you understand this? That is Refsum's disease. What are the first two letters in Refsum's disease, all of you? RE. So remember, manifestation is retinitis pigmentosa. Refsum's disease starts with RE and manifestation is retinitis pigmentosa. Along with that, they also present with cardiac conduction defect. Okay, so what are the facts that you need to know about Refsum's disease? Refsum's disease is a peroxisomal disorder. Okay, what is it? It's a peroxisomal disorder caused by the defect of one enzyme. Which enzyme? Phytanic acid oxidase. It is caused by the defect of phytanic acid oxidase. Phytanic acid is a branch chain fatty acid. So in this case, there is a defect of branch chain fatty acid oxidation. And what does it present with? All of you tell me. These are the manifestations. It would present with retinitis pigmentosa, ichthyosis, and cardiac conduction defects. But let's learn about other choices also, because other choices are also peroxisomal disorders. Zellweger syndrome. So what is Zellweger syndrome? That's also a peroxisomal disorder. It is caused by the defect of POX gene. Okay, and what is POX gene related to? It is related to pushing all enzymes into peroxisomes. Any enzyme that is destined to get into peroxisome goes with the help of POX gene. So when that is defective, you see ghost peroxisomes. What do you mean by ghost peroxisomes? You see this peroxisome as a suborganelle which is empty. No enzyme is present. Now, what are the functions of peroxisomes? Peroxisomes are related to, please remember all these functions. I do not tell you anything which is redundant. Do you all understand this? I don't say anything which is redundant to you, which is not needed to you. Take this from me. This is my 20th year. Right, this is my 20th year teaching medical post-graduation aspirants, be it NEET PG or FMG or INI-CET. So based on my experience all along in this 20 years, I know what to say, what not to say. Okay, so don't get into this FOMO mode. Don't think, okay, am I wasting my time here? Should I do something else? So remove all those, anxiety that is clouding your brain. Okay, focus and understand what are the functions of peroxisomes. The first function is very long chain fatty acid oxidation. Second is branch chain fatty acid oxidation. Third is it is related to glycine and taurine conjugation of bile acids. Yeah, what is it related to? Glycine and taurine conjugation of bile acids. Fourth is it's related to ether lipid synthesis. So all of you repeat this. This can be asked as one-liners. What are the functions of peroxisomes? Peroxisomes are related to very long chain fatty acid oxidation, branch chain fatty acid oxidation, glycine and taurine conjugation of bile acids, and ether lipid synthesis. So when there are ghost peroxisomes, none of these functions will happen. Okay, none of these functions would happen. So it's a very severe disorder. It's called the cerebrohepatorenal syndrome, right? What do you call this condition as? You call this condition as cerebrohepatorenal syndrome. Even at the time of birth, it would present with hypotonia. Do you understand this? Severe hypotonia, severe neurological manifestations at the time of birth. In that case, that is Zellweger syndrome. Are you clear? So tell me all about Zellweger syndrome. It's also a peroxisomal disorder caused by POX gene mutation. So in this case, there are empty peroxisomes. So the cell will not be able to oxidize very long chain fatty acid, no oxidation of branch chain fatty acid, no glycine and taurine conjugation of bile acids, no ether lipid synthesis. It's going to be a severe disorder. It's called a cerebrohepatorenal syndrome. It presents a severe hypotonia even at the time of birth. Okay. Now, what is adrenoleukodystrophy? Again, a peroxisomal disorder. Adrenoleukodystrophy is also a peroxisomal disorder wherein very long chain fatty acids are not able to get into peroxisome to get oxidized. Do you understand this? What is the defect here? The defect is with respect to very long chain fatty acids not being able to get into peroxisomes, caused by the defect of ABCD1. Yeah, caused by the defect of ATP binding cassette transporter D1, which is responsible for pushing very long chain fatty acids into peroxisome. So in this case, right, what would you see? Adreno. So it would present with adrenal insufficiency. Right? What would it present with? Adrenal insufficiency and demyelination manifestations. Extensive demyelination manifestations. In that case, what should you think of? You should think of adrenoleukodystrophy. Are you all clear about this? Yeah, so this is about peroxisomal disorder. So what are the three peroxisomal disorders that you have learned today? One is Refsum's disease, phytanic acid oxidase defect, presence with retinitis pigmentosa, ichthyosis, cardiac conduction defects. Second is Zellweger syndrome, peroxisomal biogenesis disorder, where none of the enzymes can get into peroxisomes. They are ghost peroxisomes, empty peroxisomes. Severe disorder, presents a cerebrohepatorenal syndrome as severe hypotonia at the time of birth. Adrenoleukodystrophy, another peroxisomal disorder. It is X-linked recessive. Adrenoleukodystrophy is X-linked recessive. Very long chain fatty acids cannot enter into peroxisome. This condition presents with adrenal insufficiency and severe demyelination disorder. Okay. Yeah, in both Refsems and Zellweger, phytanic acid will be elevated. But additionally, in Zellweger, very long chain fatty acid levels are also high. Okay, absence of ether lipids. These are additional features for Zellweger. See, one exam in FMG Jan 2026, this was asked. Much before that, in July 2024, they had asked you Zellweger syndrome. So Zellweger syndrome is due to which of the following suborganal defect? It is peroxisomal defect. Good. A child is evaluated for cardiomegaly and features of heart failure. Lab investigation shows maltase deficiency, which is the most likely diagnosis. Jan 2026 again. Okay, so just remember this: cardiomegaly. Heart is your pump, right? Heart is your pump. The pump is affected in Pompe's disease. Do you understand this? The pump is affected in Pompe's disease. So what is the right answer here? The right answer here is Pompe's disease. Okay, I'm going to tell you now about all glycogen storage disorders. How many of you want to know about glycogen storage disorders and how to make a diagnosis? If you want to know, can I see some thumbs up or likes? Yeah, do like the video. Glycogen storage disorders. Yeah, all diseases in short. I know all of you are all about short and crisp version. And yes, this is a rapid revision session. I will keep it short. Okay. So glycogen storage disorders. Before we start learning about these disorders, I'm going to tell you 5 facts, concepts. Okay. Just listen to this. Then you'll be able to understand all disorders. Okay. The first concept is there are 2 pathways which can maintain blood glucose. Are you clear? In your body, there are 2 pathways which can maintain blood glucose. One is liver glycogenolysis. The other one is gluconeogenesis. So tell me, what are the 2 pathways? One is liver glycogenolysis. The other one is gluconeogenesis. These are the 2 pathways which can maintain blood glucose. For both these pathways, there is one common enzyme, that is glucose 6-phosphatase. Yeah, glucose 6-phosphatase is an enzyme that is common to both these pathways. That is why what happens, all of you please listen to this carefully. That is why what happens whenever there is a defect of glucose 6-phosphatase. Glucose 6-phosphatase is called as von Gierke's disease. Yeah, von Gierke's disease is type 1 glycogen storage disorder. Type 1 stands for von. Type 1 is von Gierke's disease caused by the defect of glucose 6-phosphatase. When that enzyme is defective, neither glycogenolysis nor gluconeogenesis can maintain blood glucose. So what does it present as? It presents as severe fasting hypoglycemia. Do you all understand this? What would it present as? It would present as severe fasting hypoglycemia. All of you listen to this. Always type 1s are severe. In any group, type 1 is severe. Okay. So type 1 of von Gierke's disease would present a severe fasting hypoglycemia because it's a defect of glucose 6-phosphatase, and this glucose 6-phosphatase is common to both glycogenolysis and gluconeogenesis. This is the first set of facts that you need to know. Next is glycogen is stored in 2 tissues. In human body, glycogen is stored in 2 tissues. One is liver, the other one is muscle. Okay. Liver glycogen is used for maintaining blood glucose. Liver glycogen is used for maintaining blood glucose. What does it mean? When you have your food, dietary glucose will maintain blood glucose. Right? When you don't have your food, what will maintain blood glucose? It is liver glycogenolysis followed by gluconeogenesis. So what is the use of glycogen that is stored in the liver? Liver glycogen maintains blood glucose in the fasting state. Muscle glycogen cannot increase plasma glucose. Please remember, muscle glycogen cannot increase blood glucose because muscle does not have glucose 6-phosphatase. If If muscle glycogen cannot increase blood glucose, then what is muscle glycogen used for? Muscle glycogen is used only for muscle purposes. Muscle glycogen is used only for exercise. Do you understand this? Muscle glycogen is used only for exercise. Remember it this way. Your muscle is selfish. Do you get it? Your muscle is selfish. It stores glycogen. It uses glycogen only for its own purposes. It cannot increase blood glucose. Okay. So, can you tell me these 5 facts? So tell me, what are the 2 pathways which can maintain blood glucose? Glycogenolysis and gluconeogenesis. For both these pathways, what is common? Glucose 6-phosphatase is common. So whenever there is a defect of glucose 6-phosphatase or von Gierke's disease, it presents a severe fasting hypoglycemia. Glycogen is stored in liver and muscle. Liver glycogen can increase blood glucose. Muscle glycogen cannot increase blood glucose. Muscle glycogen is used only for muscle purposes. Okay. So, whenever there is a liver glycogen metabolism defect, that causes fasting hypoglycemia. Because in that case, fasting state, glucose cannot be maintained. Whenever there is a muscle glycogen metabolism defect, muscle cannot exercise. So, muscle glycogen metabolism defect will cause exercise intolerance. Okay. So, liver glycogen metabolism defect causes fasting hypoglycemia. Muscle glycogen metabolism defect causes exercise intolerance. Okay. So, have this in mind. Now, what are the types of glycogen storage disorders that you need to learn about? You have to learn 8 types of glycogen storage disorders, starting from type 0 till type 7. Right? Starting from type 0 till type 7, totally 8 types. Can you start answering? What is type 0, everybody? Type 0 is glycogen synthase deficiency. Okay, type 0 is glycogen synthase deficiency. Now, do you understand why it's called as type 0? Think. It's a glycogen storage disorder without any glycogen storage. Do you understand? It's a glycogen storage disorder without any glycogen storage. That is why it is type 0. So, type 0 is glycogen synthase deficiency. What is type 1, all of you? 1 stands for von. Right? 1 stands for von. So, 1 is von Gierke's disease. I just now told you von Gierke's disease is caused by the defect of which enzyme? Glucose 6-phosphatase enzyme. Okay. Type 2. The question was on type 2. What is type 2? Type 2 is Pompe's disease caused by the defect of acid maltase. Pompe's disease caused by the defect of acid maltase or alpha glucosidase. Acid maltase or alpha glucosidase. When you learn about alpha glucosidase, involuntarily your brain should start thinking about beta glucosidase defect. Alpha glucosidase defect is Pompe's. Beta glucosidase defect is Gaucher's. We are going to discuss about Gaucher's next. Okay. So, beta glucosidase defect causes Gaucher's. Alpha glucosidase defect causes Pompe's. Type 3. Third alphabet. Alphabetical order, third alphabet is C. So, type 3, C stands for Cory's disease. Yeah, C stands for Cory's disease. C has to be followed by D. Alphabetical order, C is to be followed by D. Cory's disease is caused by the defect of D branching enzyme. Okay, Cory's disease is caused by the defect of D branching enzyme. C and D are over, which means that next it has to be A and B. Right? Next it has to be A and B. So, what is type 4? Type 4 is Anderson's disease. Type 4 is Anderson's disease caused by the defect of branching enzyme. Okay, Anderson's disease caused by the defect of branching enzyme. Now, type 5, all of you look at Roman letter 5, it looks like the letter V. I want you to invert V, write it twice. Yeah, invert V, write it twice. What is M? Okay, so type 5, M stands for McArdle's disease. M for M, McArdle's disease is caused by the defect of muscle phosphorylase. Okay, McArdle's disease is caused by the defect of muscle phosphorylase. Type 6, Hirsch's disease. Okay, Hirsch's disease, H for H. Hirsch's disease is caused by the defect of hepatic phosphorylase or liver phosphorylase. Hirsch's disease is hepatic phosphorylase or liver phosphorylase. Type 7. Yeah, type 7 is Tarrow's disease. Type 7 is Tarrow's disease caused by the defect of phosphofructokinase 1, the rate limiting enzyme of glycolysis. Type 7 is Tarrow's disease caused by the defect of phosphofructokinase 1. So can you quickly repeat this? Yeah, look at this table. If you want, you can have a look at it or you can recollect an answer. I would say active recall always helps. So don't look at what is there. Try to recollect. Type 0, glycogen synthase deficiency. It's a glycogen storage disorder without any glycogen storage. Hence, it's called as type 0. Type 1, Von Gierke's disease, glucose 6-phosphatase defect. Type 2, Pompe's disease, acid maltase or alpha glucosidase defect. Type 3, Cory's disease, debranching enzyme defect. Type 4, Anderson's disease, A and B, right? So Anderson's disease, branching enzyme defect. Type 5, McArdle's disease, muscle phosphorylase defect. Type 6, Hirsch's disease, hepatic phosphorylase defect. Type 7, Tarrow's disease, phosphofructokinase 1 defect. Okay. Now, classification of glycogen storage disorders. Before we classify glycogen storage disorders, I am going to tell you about Pompe's disease separately. I am saying about Pompe's disease separately because it is the only glycogen storage disorder which is also a lysosomal storage disorder. Right? So whenever in the MCQ, you are saying something about glycogen, you're seeing something about glycogen and you also see the word lysosome. It is Pompe's disease. Okay. So it is the only glycogen storage disorder which is also a lysosomal storage disorder. And it is caused by the defect of acid maltase or alpha glucosidase. What does it present as? As I told you in Pompe's, the pump is affected. The pump of your body is heart. Heart is affected. It presents as cardiomegaly. Yeah, it presents as cardiomegaly, cardiomyopathy and heart failure. Not only cardiac muscle, skeletal muscle is also affected. So it presents as hypotonia. Right? When skeletal muscle is affected, it presents as hypotonia. In a newborn, hypotonia presents itself as respiratory difficulty. Right? In a newborn, hypotonia presents itself as respiratory difficulty. Later on, it presents as a floppy baby. It is one of the causes of floppy baby. Infantile Pompe's disease is rapidly progressive and death happens close to 2 years. But luckily, we have enzyme replacement therapy for Pompe's. Just remember, for alpha glucosidase defect, which is Pompe's, and beta glucosidase defect, which is Gaucher's, for both you have enzyme replacement therapy. Are you clear? So this is all about Pompe's disease. So what is so unique about Pompe's disease? Pompe's disease is the only glycogen storage disorder, which is also a lysosomal storage disorder caused by the defect of acid maltase or alpha glucosidase. And that affects heart. It presents as cardiomegaly, cardiomyopathy, heart failure. When skeletal muscle is affected, it presents as hypotonia. Newborn present with respiratory difficulty. Later on, it presents as floppy baby. Rapidly progressive disorder. Death happens close to 2 years, but we have enzyme replacement therapy. Okay, so that's all about Pompe's disease. Now, glycogen storage disorders classification. You classify glycogen storage disorders into 4 categories. The first category presents with fasting hypoglycemia. Did I tell you whenever liver glycogen metabolism is affected, it causes fasting hypoglycemia. The second category presents with exercise intolerance. Whenever muscle glycogen metabolism is affected, it presents with exercise intolerance. The third category presents with both. When both liver glycogen and muscle glycogen metabolism are affected, then they present with both fasting hypoglycemia and exercise intolerance. The last category is neither fasting hypoglycemia nor exercise intolerance. Okay, so this is about classification. Now, out of these 4 types, in the first category, okay, we have 8 types of glycogen storage disorders. What of those 8 types would fit into the first category? In the first category, starting from type 0, type 0, type 1, type 3, type 6. So tell me, what are the glycogen storage disorders which present with fasting hypoglycemia? Type 0, type 1, type 3 and type 6. What are the glycogen storage disorders which present with exercise intolerance? 0 again and odd numbers. Again 0 and odd numbers. What are the odd numbers? 3, 5 and 7. Okay, 0, 3, 5 and 7 present with exercise intolerance. What are the disorders which present with both? What are the 2 types which you see in both the lists? 0 and 3. Okay, 0 and 3 present with both fasting hypoglycemia and exercise intolerance. Now, what are the disorders which present with neither fasting hypoglycemia nor exercise intolerance? The left out disorders. What are the left out disorders? Type 2 and type 4. Okay, type 2 and type 4 present with neither fasting hypoglycemia nor exercise intolerance. Got it, everybody? Yeah, can you repeat this? Fasting hypoglycemia 0, 1, 3, 6. Exercise intolerance 0, 3, 5, 7. Both 0 and 3. Neither fasting hypoglycemia nor exercise intolerance is 2 and 4. Okay, so now let's learn about the first category. The first category which presents with fasting hypoglycemia. You know the types. What are the types? Please repeat. 0, 1, 3 and 6. Okay, what are the names? Repetition is the only way you can memorize. So please repeat it. What is type 0? Type 0 is glycogen synthase deficiency. Okay, type 0 is glycogen synthase deficiency. Type 1 is von Guericke's disease caused by the defect of glucose 6-phosphatase. Type 3, third alphabet Cory's disease caused by the defect of D-branching enzyme. Okay, Cory's disease caused by the defect of D-branching enzyme. Type 6, Hirsch's disease caused by the defect of hepatic phosphorylase or liver phosphorylase. So we know this. Till now, till this we know. Okay. Now based on this, we are going to write down features. Whenever the enzyme's name has a prefix, for example, if I say liver phosphorylase, it means the enzyme is defective only in liver. If I say muscle phosphorylase, it means the enzyme is defective only in muscle. But if the enzyme's name does not have any prefix, I am just saying D-branching enzyme, it means it's defective both in liver and in muscle. Do you understand this? If I just say D-branching enzyme, it means it's defective both in liver and in muscle. So have that in mind. Now I'm going to write down features. I said type 0 is glycogen synthase deficiency. There is no prefix, which means this enzyme is defective in both liver and in muscle. When liver glycogen is not synthesized in the fasting state, blood glucose cannot be maintained. Right? If liver cannot synthesize glycogen in the fasting state, blood glucose cannot be maintained. So that causes fasting hypoglycemia. When muscle is not able to store glycogen, then muscle cannot exercise. So that causes exercise intolerance, right? That causes exercise intolerance. That is why I told you type 0 would present with both fasting hypoglycemia and exercise intolerance. Whenever you see both fasting hypoglycemia and exercise intolerance in a child, the next step is do a liver biopsy. Right? What should be the next step? Whenever you see both fasting hypoglycemia and exercise intolerance, the next step is to do liver biopsy. In this case, liver biopsy reveals zero glycogen because glycogen synthase is defective. In this case, liver biopsy reveals zero glycogen. Hence, it's called as type 0. Do you get it? That is why it's called as type 0. So tell me all about type 0 or glycogen synthase deficiency. Repeat this. Glycogen synthase deficiency presents with both fasting hypoglycemia and exercise intolerance. Liver biopsy reveals zero glycogen in liver. That's all about type 0. Okay. Type 1. Von Gierke's disease. This I told you already. Von Gierke's disease is glucose 6-phosphatase defect. When glucose 6-phosphatase is defective, neither liver glycogenolysis nor gluconeogenesis can increase blood glucose. When both pathways cannot increase blood glucose, what would it present as? It presents as severe fasting hypoglycemia. Yeah, it would present as severe fasting hypoglycemia. There are so many causes for fasting hypoglycemia in a neonate. But every other neonate presenting with fasting hypoglycemia would respond to a counter-regulatory hormone administration. What do you mean by a counter-regulatory hormone? Anything which acts against insulin. If you give glucagon, in all other conditions, blood glucose will be increased. Okay, if you give norepinephrine, blood glucose level will increase. So, every other fasting hypoglycemic condition would respond to a counter-regulatory hormone administration. But in von Gierke's disease, it presents a severe fasting hypoglycemia which does not respond to counter-regulatory hormone administration. Do you understand this? What does it present as? It presents as severe fasting hypoglycemia which does not respond to counter-regulatory hormone administration, because whatever may be the counter-regulatory hormone that you administer, they can increase blood glucose only by stimulating glycogenolysis and gluconeogenesis. In this condition, both the pathways are defective. So, it presents a severe fasting hypoglycemia which never responds to counter-regulatory hormone administration. That is pathognomonic for this condition. Okay. Now, Cory's disease. Cory's disease is caused by the defect of which enzyme? C has to be followed by D. So, it is caused by the defect of D branching enzyme. My question to you is, does this D branching enzyme name have a prefix as liver or as muscle? No. Which means it's defective both in liver and in muscle. So, D branching enzyme which breaks down glycogen is defective in liver and in muscle. When liver glycogenolysis does not happen, that causes fasting hypoglycemia. When muscle glycogenolysis does not happen, that causes exercise intolerance. So, type 3 also presents with both fasting hypoglycemia and exercise intolerance. Just 5 minutes back I told you, whenever you see a combination of fasting hypoglycemia and exercise intolerance, you should take a liver biopsy. So, in this case, when you take liver biopsy, liver reveals an abnormal glycogen with multiple branches. It reveals an abnormal glycogen with multiple branches because it's a debranching enzyme defect. Branches have accumulated. That abnormal glycogen with multiple branches is called as limit dextrin. So, if liver biopsy reveals limit dextrin, Do you understand this? If liver biopsy reveals limit dextrin, that is Cory's disease. Cory's disease is also called as limit dextrinosis. Do you understand this? Cory's disease is also called as limit dextrinosis. So all of you tell me, listen to this, recollect and answer. What are the glycogen storage disorders which present with both fasting hypoglycemia and exercise intolerance? Type 0 and type 3. How do you differentiate type 0 and type 3? Liver biopsy. If liver biopsy reveals 0 glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is type 3. Okay, so that's all about Cory's disease. I hope you're all enjoying this part of the session, right? So many of the concepts will be clear if you understand the biochemistry part of it. Okay, so that's about Cory's disease. Now about Hirsch's disease. What is Hirsch's disease due to? Hirsch's disease is because of the defect of liver phosphorylase. When liver phosphorylase is defective, I can see so many hearts. So when liver phosphorylase is defective, in that case, liver glycogenolysis is defective, and that causes fasting hypoglycemia. Right? Now, will this fasting hypoglycemia be severe? No. This fasting hypoglycemia will be mild to moderate. Whereas in von Gierke's, it presents as severe fasting hypoglycemia. In Hirsch's disease, it presents as mild to moderate fasting hypoglycemia, because Hirsch's disease is a defect of only glycogenolysis. Right? Hirsch's disease is a defect of only glycogenolysis. What is intact? Gluconeogenesis is intact. So that can maintain blood glucose. Do you get it? So Hirsch's disease presents with mild to moderate fasting hypoglycemia, and this can respond to counter-regulatory hormone administration. Von Gierke does not respond to counter-regulatory hormone administration. Okay. So now, based on this, I am going to write down an algorithm. Right? I'm going to write down an algorithm to make a diagnosis of glycogen storage disorder if the presenting feature is fasting hypoglycemia. Right? What if the presenting feature is fasting hypoglycemia? So no mother would come and tell you that a child has got fasting hypoglycemia. Right? What would the mother say? The mother would say, my child often cries. Cry between meals, a cry which gets soothed only after feeding, right? These are the ways that she would convey to you that her child has got fasting hypoglycemia. Do you understand this? So whenever the presenting feature is fasting hypoglycemia, what should you look for? You should look for features of exercise intolerance. You check for features of exercise intolerance. What if you see features of exercise intolerance as well? Whenever you see both, what should you do? You should take liver biopsy, right? If liver biopsy, good Queen, I'm happy for you. I'm happy that you got 569 in MDS. Yeah. So what if liver biopsy reveals 0 glycogen? What is your diagnosis? If liver biopsy reveals 0 glycogen, it is type 0, which is glycogen synthase deficiency. What if liver biopsy reveals limit dextrin? If it reveals limit dextrin, then that is called as limit dextrinosis or type 3. Simple. Okay. What if there is no exercise intolerance? Only fasting hypoglycemia, no exercise intolerance. Then you look for response to counter-regulatory hormone administration. Right? What would you look for? You look for response to counter-regulatory hormone administration. If there is no response to counter-regulatory hormone administration, that is pathognomonic for von Gierke's disease. When there is response to counter-regulatory hormone administration, then that is Hirsch's disease, right? That is Hirsch's disease. So this is the algorithm that you should have to make a diagnosis whenever the presenting feature is fasting hypoglycemia. I am repeating this algorithm for your benefit. Please repeat it along with me. If the presenting feature is fasting hypoglycemia, check for features of exercise intolerance. If you see exercise intolerance as well, do a liver biopsy. If liver biopsy reveals zero glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is type 3. If there is no exercise intolerance, only fasting hypoglycemia, look for response to counter-regulatory hormone administration. If there is no response, that is pathognomonic for von Gierke's. If there is response, it is Hirsch disease. Okay. Next category, exercise intolerance. What are the types which present with exercise intolerance? 0 and then odd numbers. What are the odd numbers? 3, 5 and 7. Right? 0, 3, 5 and 7. So tell me the names. What is type 0? Type 0 is glycogen synthase deficiency. What is type 3? Type 3 is Cory's disease caused by the defect of debranching enzyme. Type 5, McArdle's disease caused by the defect of muscle phosphorylase. Type 7, Tarrow's disease caused by the defect of phosphofructokinase 1. Right? Till this we know. Now, based on this information, I am going to write down features. Okay? Already you know the features for the first two types. Tell me, what do you expect in glycogen synthase deficiency or type 0? Type 0 would present with both fasting hypoglycemia and exercise intolerance. If you take liver biopsy, it reveals 0 glycogen. Right? Cory's disease again would present with both fasting hypoglycemia and exercise intolerance. On liver biopsy, you would see limit dextrin. So these two we know already. Now I'm going to tell you about McArdle's disease. Okay. So McArdle's disease is caused by the defect of muscle phosphorylase. Listen to this carefully, please. When muscle phosphorylase is defective, muscle glycogenolysis is defective. So muscle does not get glucose for its glycolysis. Do you understand this? Muscle does not get glucose for its glycolysis. And glycolysis is necessary for anaerobic exercises. Okay. So what will McArdle's disease present as? McArdle's disease would present as exercise intolerance. Intolerance to anaerobic exercises. Do you understand this? Intolerance to anaerobic exercises. For example, clenching the fist, pushing something against resistance. These are all examples of anaerobic exercises. So what I do is, if I suspect McArdle's in a patient, what I ask the patient to do is, I would ask the patient to clench one fist. The person will be able to do this for the first 5 to 10 minutes. After the first 5 to 10 minutes, the person complains of painful muscle cramp. Right? The reason for painful muscle cramp is ATP depletion. What is the reason for painful muscle cramp? That is ATP depletion. Why ATP depletion? Just now I told you this muscle is performing some anaerobic exercise. So muscle needs glucose. That glucose should come from glycogen. But there is a glycogenolysis defect. No glucose, no ATP. Right? When there is no ATP, you must have learnt in physiology, not only to bring about contraction, even for relaxation, you need ATP. So when there is ATP depletion, the muscle is not able to relax, and that causes painful muscle cramp. Okay. And when the patient complains of painful muscle cramp, what I do is, I collect blood sample from the exercising arm. Do you understand this? I collect blood sample from the exercising arm. In that blood sample, I estimate glucose and lactate level. I would see that both glucose and lactate level are low. I would see that both glucose and lactate level are low. Why? It's because If a muscle sees that its glycogen is not able to give glucose, muscle will start taking glycogen cannot give glucose. What will the muscle do? The muscle will take glucose from the blood. Because in this case, muscle is taking glucose continuously from the blood, blood glucose level is low, right? And why is lactate level low? If you perform an anaerobic exercise, you might also get muscle cramp. But when you get muscle cramp, if your blood sample is collected, in that blood sample, lactate level will be high. Because when you do anaerobic exercise, glucose is used and lactate is released. Right? When you do anaerobic exercise, glucose is used and lactate is released. So, in your blood sample, lactate level will be elevated after an anaerobic exercise. But in a person with McArdle's, lactate level cannot increase. Why can't it increase? Muscle does not have glucose. Muscle cannot generate lactate. So, even after anaerobic exercise, lactate level is still low. That is diagnostic of McArdle's disease. Do you all understand this? So tell me, what would you expect in McArdle's disease? McArdle's disease is muscle phosphorylase defect, muscle glycogenolysis defect, muscle does not get glucose that is necessary for anaerobic exercise. So it presents as intolerance to anaerobic exercise. If the person is asked to perform some anaerobic exercise, the person can perform it for the first 5 to 10 minutes. After which the person complains of painful muscle cramp because of ATP depletion. When the person complains of muscle cramp, you collect blood sample from the exercising arm. In that blood sample, glucose and lactate are measured. Both are low. Okay, so that is about McArdle's disease. Okay, now about Taruv's disease. I said Taruv's disease is because of the defect of phosphofructokinase 1, which is the rate limiting enzyme of glycolysis. Yeah, it is the rate limiting enzyme of glycolysis. All of you remember, glycolysis is indispensable. Yeah, glycolysis is indispensable for RBCs and white muscle fibers, because glycol is the only pathway that can generate ATP even in the absence of oxygen. Do you understand this? The only pathway that can generate ATP even in the absence of oxygen is glycolysis. And there are anaerobic cells like RBCs and white muscle fibers which are totally dependent on glycolysis for their ATP production. So whenever there is a glycolytic defect, RBCs and white muscle fibers get affected. When RBCs get affected, it presents as hemolytic anemia. When white muscle fibers get affected, it presents as exercise intolerance. Yeah, it presents as exercise intolerance. So tell me, what would you see in Taruv's disease? In Taruv's disease, you don't only see exercise intolerance. Additionally, you see hemolytic anemia. Okay, additionally, hemolytic anemia. So this is about those disorders which present with exercise intolerance. What are the disorders which present with exercise intolerance? 0, 3, 5 and 7. 0 and 3 present with both fasting hypoglycemia and exercise intolerance. 5 and 7 present with only exercise intolerance. So I am going to now write down an algorithm to find out a disorder when the presenting feature is exercise intolerance. Right? Again, the mother would not come and tell you that her child has got exercise intolerance. What would she say? She would say, my child is not able to play as much as my child's friend. Or she would say, my child is not able to play as much as my friend's child. Or she would say, my child often complains of muscle cramp. Right? In all these cases, suspect exercise intolerance. Right? If there is exercise intolerance, check. Check if there is fasting hypoglycemia as well. If there is exercise intolerance, check if there is fasting hypoglycemia as well. If yes, please tell me the answer. If you see both, close your eye and say you would ask for liver biopsy. You know that, right? If you see both, you would ask for liver biopsy. If liver biopsy reveals 0 glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is type 3. This we know. Okay. What if there is no fasting hypoglycemia, only exercise intolerance? No fasting hypoglycemia, only exercise intolerance. Check for hemolytic anemia features. Right? Check for hemolytic anemia features. What are the features of hemolytic anemia? The first feature is LDH elevation. Yeah, the first feature is LDH elevation. Otherwise, bilirubin is elevated. Reticulocyte count is high. So, look for all these features of hemolysis. If yes, I see exercise intolerance and hemolytic anemia, then that is glycolytic enzyme defect. Then what is that? That is glycolytic enzyme defect, which is type 7 or Taruv's disease. If there is no hemolysis, only exercise intolerance, then that is type 5 or McArdle's disease. You understand this? Then that is type 5 or McArdle's disease. So tell me the algorithm for exercise intolerance. If it's exercise intolerance, check for features of fasting hypoglycemia. If you see both, take liver biopsy. If liver biopsy reveals 0 glycogen, it is type 0. If liver biopsy reveals limit dextrin, it is type 3. Okay. No fasting hypoglycemia, only exercise intolerance. Then you look for features of hemolytic anemia. If you see features of hemolytic anemia, then it is glycolytic enzyme defect. No hemolytic anemia, only exercise intolerance is McArdle's disease. Okay, good. Now, the last category, neither fasting hypoglycemia nor exercise intolerance. What are the types which fit into this category? Type 2 and type 4. Type 2 we learnt already, which is Pompe's disease. Tell me, what do you see in Pompe's disease? Cardiomegaly, cardiomyopathy, heart failure, hypotonia, right? Respiratory difficulty. So that is type 2. Type 4. Okay, what is type 4? I told you type 4 is Anderson's disease caused by the defect of branching enzyme. Anderson's disease caused by the defect of branching enzyme. So in this condition, liver accumulates an abnormal glycogen without branches. Because it's a branching enzyme defect, in this condition, liver accumulates an abnormal glycogen without any branches. Branches provide compactness to glycogen. So in this condition, a large glycogen which is not compact accumulates, that causes liver cell to enlarge. So this presents as hepatomegaly. Yeah, because glycogen in this condition is large, it presents as hepatomegaly that progresses to liver cirrhosis. Just because we say Anderson presents with neither fasting hypoglycemia nor exercise intolerance, don't think of it as a milder condition. It starts as hepatomegaly that progresses to liver cirrhosis. Okay. So now you know the answer, right? Maltase deficiency, cardiomegaly, heart failure. Then what is your answer? Your answer should be Pompe's disease. A child presents with hepatosplenomegaly, anemia and bone pain. Histopathological examination reveals macrophages with a crumpled tissue paper appearance. So all these are pathognomonic, right? Crumpled tissue paper appearance, all this is Gaucher's disease. And they've told you cerebrosidus accumulated. I said Gaucher's disease is caused by the defect of which enzyme? Beta glucosidase or beta glucosyl cerebrosidase defect. Right? Beta glucosidase or beta glucosyl cerebrosidase defect. So what is the right answer here? The right answer here is choice C, because it is Gaucher's disease. But I know you all want to learn about all glycosphingolipidoses, don't you? Yeah, all types of glycosphingolipidoses. So I'm going to quickly, in a nutshell, in the next 10 minutes, right? In the next 10 minutes, we are going to learn about all glycosphingolipidoses, how to make a diagnosis given a set of features. Okay, so first we are going to fill up this table. Okay, so the first one is beta galactosidase defect. Okay, beta galactosidase defect causes GM1 gangliosidosis. Please memorize as and when I tell you. Beta galactosidase defect causes GM1 gangliosidosis. Alpha galactosidase defect causes Fabry's disease. Okay, alpha galactosidase defect causes Fabry's disease. Hexosaminidase A defect. Okay, hexosaminidase A defect causes Tay-Sachs. Hexosaminidase A and hexosaminidase B defect. When hexosaminidase A and hexosaminidase B are defective, that causes Sandoff disease. Collectively, Tay-Sachs and Sandoff are called as GM2 gangliosidosis. Yeah, collectively, Tay-Sachs and Sandoff are called as GM2 gangliosidosis. And then we have neuraminidase. The next enzyme is neuraminidase defect causes sialidosis. Okay. Then you know beta glucosidase defect or beta glucosyl cerebrosidase defect. That causes Gaucher's disease. The last one is ceramidase defect. Okay, ceramidase defect causes Farber's disease. The last one is Farber's disease. So can you all repeat this? I want you to be very clear about these enzyme names. All of you tell me, beta galactosidase defect causes which condition? It is GM1 gangliosidosis. Alpha galactosidase defect causes which condition? Fabry's disease. Okay. Beta glucosidase defect causes Gaucher's. Alpha glucosidase defect causes Pompe's. Yeah, no confusion with respect to all these four names. I'm repeating it. Beta galactosidase defect is GM1 gangliosidosis. Alpha galactosidase defect is Fabry's disease. Beta glucosidase defect is Gaucher's. Alpha glucosidase defect is Pompe's. Okay. Apart from this, we have learned hexosaminidase A defect is Tay-Sachs. Hexosaminidase A and B defect cause Sandoff. Together, Tay-Sachs and Sandoff are called as GM2 gangliosidosis. Yeah, together Tay-Sachs and Sandoff are called as GM2 gangliosidosis. Neuraminidase defect causes sialidosis. Beta glucosidase defect causes Gaucher's disease. Ceramidase defect causes Farber's disease. Now, let's learn about features. Okay, so first about GM1 gangliosidosis. The entire structure GM1 ganglioside accumulates. This GM1 ganglioside is present in neurons, present in organs, present in skeletal tissue. So what does it present with? It presents with neurological manifestations. Right? GM1 gangliosidosis presents with neurological manifestations, organomegaly and skeletal deformities. All systems are affected. Okay. So in GM1 gangliosidosis, what do you see? You see neurological manifestations, organomegaly and skeletal deformities. Now about Fabry's disease. They often ask you about Fabry's disease. Please start by telling me which enzyme defect causes Fabry's disease. It is alpha galactosidase. Okay. And if they ask you which lipid accumulates, yeah, which lipid accumulates in Fabry's disease, it is globoside. Yeah, it is globoside. And pattern of inheritance. Yeah, pattern of inheritance, it is X-linked recessively inherited. Did I tell you adrenoleukodystrophy is X-linked recessive? Fabry's disease is also X-linked recessively inherited. Now, what are the clinical features of Fabry's disease? Fabries, remember fabric, right? Most of us want a fabric to be colorful. If not boys, right? Girls want their fabric to be colorful. So remember, Fabry's disease is a colorful disorder. It presents with reddish purple spots. Those reddish purple spots are angiokeratomas. Okay, so many a times a patient of Fabry's disease would suspect some dermatological disorder, will be visiting a dermatologist. In reality, it is angiokeratoma. So it starts as angiokeratoma. Slowly they present with proteinuria that progresses to massive proteinuria. Okay, they then present with chronic kidney disease and early myocardial infarction. Chronic kidney disease and early myocardial infarction. So these are the facts that you need to know about Fabry's disease. All of you tell me about Fabry's disease. Which enzyme defect causes Fabry's disease? Alpha galactosidase. Which lipid accumulates in Fabry's disease? It is globoside. Pattern of inheritance, X-linked recessive. Clinical features, I said it starts as reddish purple spots, which are angiokeratomas. Then they present with proteinuria that progresses to massive proteinuria, chronic kidney disease, and early myocardial infarction. Okay, so that's all about Fabry's disease. So can you focus on this session first, please? Yeah. So now about hexosaminidase A defect, which is Tay-Sachs disease. What do you expect in Tay-Sachs disease? Tay-Sachs also presents with neurological manifestations, right? It also presents with neurological manifestations, but classically no organomegaly. Absence of organomegaly, absence of hepatosplenomegaly is pathognomonic for Tay-Sachs disease. Okay, and they present with cherry red spots. So tell me all about Tay-Sachs disease. Tay-Sachs disease presents with neurological manifestations, no organomegaly, and cherry red spot. A similar presentation, neurological manifestations with organomegaly, with cherry red spot, right? And that is Niemann-Pick. Do you understand this? So remember Tay-Sachs and Niemann-Pick. Tay-Sachs, neurological, no organomegaly, cherry red spot. Niemann-Pick, neurological manifestations with organomegaly, with cherry red spot. Okay. Now Sandoff. Before we start discussing about Sandoff, because we have started discussing about cherry red spot, let me give you one mnemonic related to cherry red spot. Cherry red spots are not seen in KGF. Yeah, cherry red spots are not seen in. Have you all seen this movie? Yeah, have you all seen this movie KGF? In movie, KGF stands for Kolar Goldfield. Here, KGF stands for Krabs disease, Gaucher's disease, and Fabry's disease. Okay, so cherry red spots are not seen where? It is not seen in Krabs, Gaucher's, and Fabry's. One more mnemonic. Okay, no mental retardation in GF. What is it? No mental retardation in GF. Don't we always say that girlfriends are smart? Right? Girlfriends are smart. So remember that no mental retardation GF. What does GF stand for? Gaucher's and Fabry's. No mental retardation. Okay. So these are the two mnemonics that you should remember. Now, apart from this, let's go back to Sandoff. Okay. So Sandoff and Tay-Sachs. Neurological manifestation, cherry red spot, with or without organomegaly. Do you understand this? Sandoff, neurological manifestation, cherry red spot, with or without organomegaly, which means clinically you cannot differentiate Tay-Sachs and Sandoff. Clinically, both Tay-Sachs and Sandoff present with similar manifestations, because even in Sandoff, most of the times you don't see organomegaly. So clinically, you cannot differentiate these two conditions. You have to differentiate these two conditions only biochemically. In Tay-Sachs, only GM2 ganglioside accumulates. In Sandoff, there is an accumulation of both GM2 ganglioside and globocyte. Do you understand this? So how do you differentiate Tay-Sachs and Sandoff? In Tay-Sachs, there is an accumulation of only GM2 ganglioside. In Sandoff, there is an accumulation of both GM2 ganglioside and globocyte. Okay, that is why I told you Tay-Sachs and Sandoff are collectively called as GM2 gangliosidosis. Now, neuraminidase defect or sialidosis presents with generalized swelling. Yeah, neuraminidase defect or sialidosis presents with generalized swelling or anasarca. Apart from generalized swelling, it presents with something similar to GM1 gangliosidosis. So, generalized swelling, neurological manifestations, organomegaly, skeletal deformities. That is neuraminidase defect or sialidosis. Okay. So now about beta glucosidase defect or Gaucher's disease. Let's learn about Gaucher's disease now. Please repeat this. Which enzyme defect causes Gaucher's disease? The enzyme is beta glucosidase. It is also called as beta glucosyl cerebrosidase. Okay, beta glucosyl cerebrosidase. Tell me which lipid accumulates in this condition. It is glucosyl ceramide or glucosyl cerebroside. Right? What accumulates here? Glucosyl ceramide or glucosyl cerebroside. And where do you see this glucosyl cerebroside? Glucosyl cerebroside is present in RBC membrane and platelet membrane. So in Gaucher's disease, RBCs and platelets get to have some abnormal membrane. Do you understand this? In Gaucher's disease, RBCs and platelets get to have some abnormal membrane which are not getting metabolized by the system. So these cells with abnormal membrane will get engulfed by macrophages. Because repeatedly RBCs and platelets are getting engulfed, that causes anemia. Do you understand this? That causes anemia and thrombocytopenia. So what will be the presentation of Gaucher's disease? Gaucher's disease, the presentation is almost always the same. They would always say a child presents with refractory anemia and thrombocytopenia. Right? Present with refractory anemia and thrombocytopenia. Apart from this, after macrophages engulf these cells, the cell membrane of these cells would accumulate. Even within macrophages, these cell membrane cannot be metabolized. So within these macrophages, these cells with abnormal membrane would accumulate like fibrils. This is called as crumpled tissue paper appearance. So the history is always refractory anemia with thrombocytopenia. To find out the cause of refractory anemia and thrombocytopenia, bone marrow biopsy was done. Histopathological examination of bone marrow biopsy reveals crumpled tissue paper appearance. Right? It reveals crumpled tissue paper appearance wherein you will be shown a histopathological slide with a blue color cell with fibrils. That is called as crumpled tissue paper appearance. Not just this, whenever there is anemia, there will be compensatory erythropoiesis. This compensatory erythropoiesis causes bone marrow expansion. When bone marrow expands, that causes bone erosion. This bone erosion causes bony pain. So the child often complains of bony pain like knee pain. To find out the cause of knee pain, X-ray is taken. And X-ray shows the distal end of the femur. Yeah, X-ray shows the distal end of the femur to look like a conical flask. So this is called as Erlen-Meyer flask deformity. Right? What do you call it as? You call it as Erlen-Meyer flask deformity. This is because of bone marrow expansion and bone erosion. The distal end of the femur looks like a conical flask. Compensatory erythropoiesis also happens in liver and spleen. That causes hepatosplenomegaly. Okay. And enzyme replacement therapy is available for Gaucher's. Do you understand this? Enzyme replacement therapy is available for Gaucher's. So can you all repeat this about Gaucher's? Tell me which enzyme defect causes Gaucher's disease. Answer please. Which enzyme defect causes Gaucher's disease? It is beta glucosidase or beta glucosyl cerebrosidase. The lipid which accumulates is glucosyl cerebroside. It's present in RBC membrane and platelet membrane. So in this condition, these cells with abnormal membrane get engulfed by macrophages, causing refractory anemia and thrombocytopenia. Okay. Bone marrow biopsy reveals crumpled tissue paper appearance on histopathological examination. And for refractory anemia, compensatory erythropoiesis happens that causes bone marrow expansion and bone erosion, bony pain. And distal end of the femur looks like a conical flask. That's called as Erlen-Meyer flask deformity. And there is hepatosplenomegaly. Enzyme replacement therapy is available. Okay. So that is all about Gaucher's disease. Now the last one. Right, the last one is ceramidase defect of Farber's disease. And Farber's disease is a granulomatous disorder. Yeah, Farber's disease is a granulomatous disorder. It presents with painful subcutaneous nodules and chronic kidney disease. It presents with painful subcutaneous nodules and chronic kidney disease. That's about Farber's disease caused by the defect of ceramidase. Okay. So, few points to remember. Okay, few points to remember. The first one is a mnemonic which I gave you. What is the mnemonic I told you? No mental retardation in GF. Right? No mental retardation, Gaucher's disease and Fabry's disease. Second one, no cherry red spot in KGF. So, no cherry red spots in Crab's, Gaucher's and Fabry's. Okay, no cherry red spot in Crab's, Gaucher's and Fabry's. No hepatosplenomegaly. What did I tell you? No hepatosplenomegaly in Tay Sachs and in Crab's disease. Okay, and then I told you about GM2 gangliosidosis includes Tay Sachs and Sandoff. And the last fact that I want you to remember is Sandoff, there is an accumulation of both GM2 ganglioside and globoside. Do remember, if they say cherry red spot with neurological manifestations and organomegaly, if you see all these three, that is Niemann-Pick disease, right? That is called as Niemann-Pick disease. So what is the answer here? Hepatosplenomegaly, anemia and bone pain. Histopathological examination reveals crumpled tissue paper appearance. It is Gaucher's disease caused by the defect of beta glucosidase or beta glucosyl cerebrosidase. Yeah. Answer this. A child presents with hepatosplenomegaly. Histopathological examination reveals foam cells due to lipid accumulation. What is the most likely diagnosis? If it's hepatosplenomegaly with foam cells, it is Niemann-Pick. Caused by the defect of sphingomyelinase. Niemann-Pick is caused by the defect of sphingomyelinase. Good. Another MCQ, cherry red spot without organomegaly. Cherry red spot without organomegaly is Tay Sachs. A child presents with self-mutilating behavior. The moment you see self-mutilating, what is self-mutilating? Bites nails, bites lips. Okay, so that is called as self-mutilating behavior, developmental delay and hyperuricemia. So what is the answer? The deficiency of which enzyme? The diagnosis is Lech-Nyhan syndrome. What is the diagnosis? It is Lech-Nyhan syndrome caused by the defect of hypoxanthine guanine phosphoribosyl transferase enzyme. Caused by the defect of hypoxanthine guanine phosphoribosyl transferase. So I'm going to give you a mnemonic for Lech-Nyhan syndrome. The mnemonic is leash. The mnemonic is leash. What does L stand for? Lips are bitten, right? Lips are bitten, nails are bitten. Okay. E stands for high uric acid. E stands for excessive uric acid. S stands for self-mutilating behavior. C stands for chorioathetosis, right? C stands for chorioathetosis. H stands for hypoxanthine guanine phosphoribosal transferase defect. Okay. So what does leash stand for? Lips and nails are bitten. E stands for excessive uric acid. S stands for self-mutilation. C stands for chorioathetosis caused by the defect of hypoxanthine guanine phosphoribosal transferase. And not just this question, they have asked you so many questions on Lech-Nyhan syndrome. For example, check this. This was asked in FMG July 2024. A couple presents to the OPD with their 4-year-old child who has self-mutilating behavior and poor growth. Identify the condition and the enzyme involved in it. What is the condition? Lech-Nyhan syndrome, and it is HGPRTase deficiency. Good. Again, this is a frequently asked topic. Connective tissue disorders. Okay. A tall individual with long limbs and large hands is suspected to have Marfan syndrome. Marfan syndrome is caused by a defect of which gene? It is fibrillin gene. Marfan syndrome is fibrillin gene. So fibrillin gene mutation causes Marfan syndrome, when you see a tall individual with long arm span, arachnodactyly, right? And they present with subluxation of lens. Remember this, bilateral, spontaneous, yeah, right? Bilateral, spontaneous, superotemporal dislocation of lenses, Marfan syndrome. Infranasal dislocation of lenses, homocystinuria. Okay, so what are the points that you should remember about Marfan syndrome? It's a connective tissue disorder caused by the defect of fibrillin gene. Here is a patient who's presenting who's a tall individual with long arm spans, arachnodactyly. They present with bilateral superotemporal dislocation of lens. You're more worried about this condition because they can anytime present with aortic dissection. Right? That is why we are worried about this condition. There is something called a cystic medial necrosis of aorta. So they can anytime present with aortic dissection, and that is what you should remember about Marfan syndrome. Okay. Now what about other choices, everybody? Collagen type 1. Collagen type 1 defect is osteogenesis imperfecta. Right, collagen type 1 defect is osteogenesis imperfecta. The child presents with blue sclera, right, and pathological fractures. Okay. Elastin. Elastin defect is called as Williams syndrome. Okay, defect of elastin is called as Williams syndrome. Williams syndrome presents with supravalvular aortic stenosis. Okay, Williams syndrome presents with supravalvular aortic stenosis. Dystrophin, we all know, right? Dystrophin mutation causes what? Duchenne's muscular dystrophy. Are you clear about all these choices? Yeah, so Marfan's is fibrillin mutation. Collagen type 1 mutation causes osteogenesis imperfecta. Elastin mutation causes Williams syndrome. Dystrophin defect causes Duchenne's muscular dystrophy. So this was asked in FMG Jan 2026. Again, in July 2025, in the same exam, there were 2 questions. Same exam, 2 questions on Marfan syndrome. Look at this. A 17-year-old tall male presents for a routine checkup. He has long limbs, arachnodactyly, hypermobile joints, high arched palate, high arm span. Which of the following genetic mutation is likely responsible for this condition? Marfan syndrome, fibrillin mutation, right? Again, the same exam, July 2025. A 17-year-old tall male, I'm not very sure about the age, came for a routine checkup. He has long limbs, arachnodactyly. Fibrillin 1 gene was found to be defective. What is the associated disorder? Yeah, what is the associated disorder? Marfan syndrome. Yeah, they love Marfans for some reason. So now, ABG, right? Have you seen many MCQs on ABG interpretation? They always ask you, okay? So let's try to understand about this. A patient presents with shortness of breath. Arterial blood gas analysis shows pH of 7.3, PCO2 30 millimeters of mercury, and bicarbonate 22. Interpret the acid-base status of this patient. Okay, I'll quickly tell you the answer and then I'm going to tell you how to approach any ABG-based MCQ. Okay, in this case, pH is low because the normal pH is 7.36 to 7.44. In this case, the pH is low. So it is acidosis. Do you understand this? It is acidosis. Now look at PCO2. What is the normal PCO2? Remove this 7. Yeah, it is 36 to 44 millimeters of mercury, which is the normal PCO2. In this case, PCO2 is also low. Okay. Can low PCO2 ever cause acidosis? Listen to me carefully. Carbon dioxide is a source of acid. Are you clear? Carbon dioxide is a source of acid. So whenever carbon dioxide concentration decreases, acid concentration decreases, it should cause only alkalosis. Do you understand this? It should cause only alkalosis. So decrease in PCO2 can only explain alkalosis. Here you know it is acidosis. So this decrease in PCO2 is not the cause. Right? So what should be the cause? Decrease in bicarbonate should be the cause. If decrease in bicarbonate causes acidosis, then that is metabolic acidosis. For now, just remember the answer is choice C, which is metabolic acidosis. But don't lose your heart. If you have not understood it enough, don't lose your heart, because I'm going to tell you how to interpret any ABG report with 3 steps. Yeah, you need to know just 3 steps. Okay. So before we get into the 3 steps of ABG interpretation, I am going to give you normal values. I want you to memorize those values. Okay. So what is the normal pH? Normal pH is 7.36 to 7.44. Have you all memorized it? Normal pH is 7.36 to 7.44. What is the normal PCO2? For PCO2, take off this 7. Right? What do you have? 2 numbers, 36 to 44 millimeters of mercury. Normal PCO2 is 36 to 44 millimeters of mercury. What is the normal bicarbonate? Normal bicarbonate is 24. On either side, you can have 3. Normal bicarbonate is 24. On either side, you can have 3. So it is 21 to 27 milliequivalents per liter. Have you all memorized these normal values? Okay, so these are the normal values. Now step number 1. Step number 1 is to check the pH. We know the range. What is the range? 7.36 to 7.44 is the normal range. What if the pH is less than 7.36? If the pH is less than 7.36, it is acidosis. If the pH is more than 7.44, that is alkalosis. Clear? Less than 7.36 is acidosis, more than 7.44 is alkalosis. But remember, a normal pH within the range of 7.36 to 7.44 does not exclude an acid-base disorder. A normal pH within the range of 7.36 and 7.44 does not exclude an acid-base disorder. It can be a mixed acid-base disorder. For example, what if your patient has got a combination of metabolic acidosis and metabolic alkalosis? Right? What if your patient has got a combination of metabolic acidosis and metabolic alkalosis? Acidosis and alkalosis effect will cancel each other. The pH will be in the normal range, but the person is suffering from an acid-base disorder. Do you get it? Now you should ask me, how can a patient simultaneously present with metabolic acidosis and metabolic alkalosis? Is this combination possible? Yes, this is possible. Like what I told you when I started the session, I do not say anything which is not necessary to you. I am saying this for a reason, because previously in FMGE, they've asked you this twice. Okay, so listen to this part of the session carefully. When can there be a combination of metabolic acidosis and metabolic alkalosis? Example is a diabetic individual. Okay, a diabetic individual has dined out, right? The diabetic individual has had food outside, and now the person is presenting with food poisoning. Because of this food poisoning, there is severe vomiting. Do you understand this? Because of this food poisoning, there is severe vomiting. Vomiting causes metabolic alkalosis, right? Vomiting causes metabolic alkalosis. I am going to tell you how. Okay, please don't just memorize anything. If you memorize, you won't be able to answer many MCQs. Don't think FMG is a factual exam. FMG is a highly conceptual exam. Okay, I'm explaining this for a reason, because I'll show you another question which was asked previously. I'm going to explain how does vomiting cause metabolic alkalosis. Not because you're vomiting out acid, but because you're vomiting out chloride. Right? If you're vomiting out frequently, you're losing hydrochloric acid, chloride is lost. So the first electrolyte abnormality that you see in a patient who's vomiting is hypochloremia. Okay? Whenever there is hypochloremia, JG apparatus is stimulated. Right? What is stimulated? JG apparatus is stimulated. This JG apparatus releases renin. Okay, renin produces angiotensin 2. Do you understand this? Renin produces angiotensin 2. Angiotensin 2 releases aldosterone. Angiotensin 2 releases aldosterone. This is called the secondary hyperaldosteronism. Do you understand this? So tell me, what does vomiting cause? Vomiting causes hypochloremia. Hypochloremia stimulates JG apparatus. Renin is released, angiotensin 2 is produced, aldosterone is secreted. What does aldosterone do? Aldosterone acts on the late distal convoluted tubule, wherein aldosterone causes sodium and water reabsorption. Don't you want this to happen? If a person is vomiting, the person is getting dehydrated. To avoid the effect of dehydration, what should you do? You should increase sodium and water reabsorption. Whenever sodium is reabsorbed by aldosterone, it causes reciprocally potassium and H plus secretion. What does DCT do? It reabsorbs sodium and water, but it reciprocally causes potassium and H plus secretion into the renal tubule. Tell me, what will happen when there is potassium secretion? It causes hypokalemia. Potassium secretion causes hypokalemia. What happens when acid is secreted into urine? You're losing acid in the urine. Acid is lost, that causes metabolic alkalosis. Because acid is lost, that causes metabolic alkalosis. So do you understand that metabolic alkalosis is caused in vomiting because of secondary hyperaldosteronism? Do you understand this? Metabolic alkalosis seen in vomiting because of secondary hyperaldosteronism. So all of you tell me, whenever there is severe vomiting, what are the abnormalities that you are going to expect? Hypochloremia, hypokalemia, metabolic alkalosis. Do you understand this? Hypochloremia, hypokalemia, metabolic alkalosis. This has been asked twice in FMG. There is a probability that this is asked in the upcoming exam. So you should not make a mistake. Vomiting causes hypochloremia, hypokalemia and metabolic alkalosis. So coming back to what I was telling you, A diabetic individual is now presenting with food poisoning and vomiting. Vomiting causes metabolic alkalosis. A diabetic individual who's stressed, right? A diabetic individual who's stressed would present with diabetic ketoacidosis. Ketoacidosis causes metabolic acidosis. So here is a patient who's presenting with a combination of metabolic alkalosis and acidosis. So pH will be in the normal range. But the person is suffering from an acid-base disorder. That is why even if you see the pH to be in the normal range, don't stop there. Go ahead, check bicarbonate and PCO2. Only when all three values are normal, the person is in an acid-base balance. Even if one of these three values are affected, the person is suffering from an acid-base disorder. That's all about step 1. So what is step 1 for? Step 1 is to find out whether it is acidosis or is it alkalosis. Okay. Now step number 2. Step number 2 is to find out whether it is metabolic or respiratory. Do you understand this? What is step number 2 for? It is to find out. All of you, please watch what I am telling you. I am going to tell you about compensation also. Please don't get into this FOMO mode. I cannot repeat this. Okay. Listen to this. So what is step number 2? Step number 2 is to find out whether it is metabolic or respiratory. How will you find out whether it is metabolic or respiratory? By checking PCO2 and by checking bicarbonate. Do you understand this? By checking PCO2 and by checking bicarbonate. Okay. So, for you to understand how to perform step 2, I'll first tell you what you should do for acidosis and then I'll tell you what you should do for alkalosis. Okay. So, acidosis is either because of decrease in bicarbonate. Acidosis either because of decrease in bicarbonate or it is because of increase in PCO2. Okay, you should ask me why. Because bicarbonate is a major plasma buffer. So for any reason, if you have lost this buffer, right? If for any reason, if you have lost this buffer, none of the metabolic acids can be buffered. So all metabolic acids accumulate. That causes metabolic acidosis. Okay. So if decrease in pH is because of decrease in bicarbonate, that is called as metabolic acidosis. How can an increase in PCO2 cause acidosis? Because carbon dioxide is a source of an acid, as I told you. So for any reason, if carbon dioxide accumulates, that causes acidosis and that is called as respiratory acidosis. Right? That causes acidosis. That's called as respiratory acidosis. Now, you should tell me for alkalosis. Can you keep the live chat active, please? Tell me about alkalosis. Alkalosis either because of increase in bicarbonate or it is because of decrease in PCO2. Do you understand this? Alkalose either because of increase in bicarbonate or because of decrease in PCO2. If you're asking me how can an increase in bicarbonate cause alkalosis, it's because bicarbonate is a buffer. For any reason, if you accumulate this buffer buffers all metabolic acids, causing metabolic alkalosis. Why should a low PCO2 cause alkalosis? Carbon dioxide is a source of an acid. By any mechanism, if you have gotten rid of that acid, that causes alkalosis and that is respiratory alkalosis. Right? Are you all clear about this till now? Good. Now look at these values and give me the answer. What do you see here? pH is low. So what is your diagnosis? It is acidosis. Okay. And then you're checking PCO2. 36 to 44 is the normal range. Here PCO2 is low. Please tell me now, can a low PCO2 explain acidosis? Low PCO2 can only explain alkalosis. So this is not the primary acid-base disorder. Do you understand this? This is not the primary acid-base disorder. Bicarbonate is 24, which is normal. Here bicarbonate is in the low normal range. Bicarbonate is in the low normal range and there is acidosis. So what is your diagnosis? Your diagnosis is metabolic acidosis. Do you understand this? What is it? It is metabolic acidosis. Is it clear, everybody? Good. Interpret the acid-base status for the following lab values. Bicarbonate is 14, PCO2 is 24, pH is 7.4. Okay. So what is step number 1? pH. What did I tell you? The normal value is 7.36 to 7.44. It is normal. I said even if the pH is normal, go ahead and check bicarbonate. Right? So if you check bicarbonate, bicarbonate is low and PCO2 is also low. Low bicarbonate and low PCO2. Okay, so the person is not in acid-base balance. There is some acid-base disorder which has caused compensation. Right? The compensation is so effective that the pH is in the normal range. So what is the disorder? That is a possibility. If low bicarbonate is the primary acid-base disorder, then it is metabolic acidosis. Right? It is metabolic acidosis with respiratory compensation. If low PCO2 is the cause, then it is respiratory alkalosis with compensation. Do you understand this? So it is either metabolic acidosis with compensation or it is respiratory alkalosis with compensation. These are the two possibilities. So can you check all these choices? You see metabolic acidosis with compensation. I don't see respiratory alkalosis with compensation at all. So this is not the right answer. What is the right answer? Metabolic acidosis with compensation. Do you all understand this? Yeah? Okay. But I'm going to tell you about compensation now. Okay. So this we did not have to calculate compensation, but I'm going to tell you about compensation, which is done in step 3. Okay. So step 3 is to find out whether there is appropriate compensation or no. What is it used for? It is to find out whether there is appropriate compensation or no. So now I'm going to tell you the basics of compensation. The basics of compensation is if the primary disorder is metabolic. If the primary disorder is metabolic, lungs compensate. Okay. So what does it mean? If the primary disorder is respiratory. If the primary disorder is respiratory, what would compensate? Kidneys will compensate. Do you all understand this? If the primary disorder is metabolic, lungs compensate. If the primary disorder is respiratory, kidneys compensate. For example, in metabolic acidosis. Tell me what is metabolic acidosis. Metabolic acidosis is decrease in pH caused by a decrease in bicarbonate. Metabolic acidosis is decrease in pH caused by a decrease in bicarbonate. The compensation should be a decrease in PCO2. The compensation should be a decrease in PCO2. Now you should ask me 2 questions. Your first question should be, how can a decrease in PCO2 compensate for metabolic acidosis? And how does that happen? Right? So decrease in PCO2 can definitely compensate for acidosis because carbon dioxide is a source of an acid. You're getting rid of a source of an acid. So that will compensate for acidosis. So we now know in metabolic acidosis caused by a decrease in bicarbonate, the compensation should be a decrease in PCO2. But how does this happen? It happens because for any reason, if there is metabolic acidosis, hydrogen ion in the CSF increases. Whenever hydrogen ion in the CSF increases, that stimulates the respiratory center. So the person hyperventilates. The person washes away carbon dioxide, decreasing carbon dioxide. That is the expected compensation. This you know already, don't you? You know, right? Whenever there is metabolic acidosis, haven't you learned that there is Kussmaul's breathing? Yeah, whenever there is metabolic acidosis, there is always Kussmaul's breathing. So why do you see Kussmaul's breathing? It is the body's way of compensating for metabolic acidosis. Do you understand this? It's body's way of saying, I will stop the session at 11:30. Okay. Actually, today is my birthday. I mean, midnight is my birthday. So I will definitely stop the session at 11:30. We'll try to finish it before that. Okay. So this is about compensation. So do you understand that the compensation is always parallel? Yeah. Do you understand that the compensation is parallel? So what do you mean by parallel compensation? If the primary defect is a decrease in bicarbonate. Yeah. Thanks everybody. Thank you. Yeah. Let's focus on this session. Yeah. So if the primary defect is a decrease in bicarbonate, thanks a lot. If the primary defect is a decrease in bicarbonate, the compensation is a decrease in PCO2. If the primary defect is an increase in bicarbonate, the compensation is an increase in PCO2. And the reverse is also true. If the primary defect is a decrease in PCO2, the compensation is a decrease in bicarbonate. If the primary defect is an increase in PCO2, the compensation is an increase in bicarbonate. So this is what you need to know about compensation. Compensation is always parallel. Thanks all of you. LRR cake cutting. Yeah. So what is the right answer? The right answer is metabolic acidosis with compensation. I'm so blessed to have your wishes and love. So a patient presents with history of vomiting. Now you can start answering everybody because you know the basics. A patient presents with history of vomiting. Arterial. So what do you expect if there is vomiting? Can you first give me that answer? Vomiting causes metabolic alkalosis. Right? Vomiting causes metabolic alkalosis. Let's see if it's metabolic alkalosis. Look at these values. pH 7.5. So pH is high, which means it is alkalosis. Okay. Now check PCO2. 36 to 44 is the normal range. Here PCO2 is high. Can a high PCO2 ever explain alkalosis? High PCO2 can only explain acidosis. So this is not the primary acid-base disorder. Okay. Look at bicarbonate 21 to 27. Here the bicarbonate is high. Can a high bicarbonate explain alkalosis? Yes. And what is it? It is metabolic alkalosis. Okay. So we expect metabolic alkalosis for this history of vomiting. Based on values also you find metabolic alkalosis. Yeah, you will all be young as me. So interpret this all of you. pH 7.36 to 7.44. pH is low. So what is it? It is acidosis. Look at PCO2. PCO2 is low. That cannot explain acidosis. Look at bicarbonate. Bicarbonate is low. That can explain acidosis. So what is it? It is metabolic acidosis. I told you, right? This was asked previously. A neonate presents with recurrent projectile vomiting, which is non-bilious. What is the electrolyte abnormality that is expected in this condition? Projectile vomiting, what do you expect all of you? Hypochloremia, right? Hypochloremia, hypokalemia, and metabolic alkalosis. So the right answer is choice B. Yeah, birthday rapid revision. A patient presents with hepatomegaly and joint pain. Investigations suggest abnormal intracellular accumulation of macromolecules such as lipids or glycoconjugates. Which cellular organelle is primarily responsible for this accumulation? Right. So there is something which is not getting metabolized. There is no defect in synthesis. There is a defect in metabolizing macromolecules. Which of these suborganelles are involved in metabolizing macromolecules? It is lysosomes. Do you understand that? It is lysosome. So what is the right answer? The right answer is lysosome. When this question was asked, many chose Golgi complex, because they have learned that Golgi complex is related to glycoconjugate formation. But understand, Golgi complex is related only to formation of glycoconjugates. If that is defective, there would be no glycoconjugate. If glycoconjugate accumulates, it means glycoconjugate is not getting metabolized. Which suborganel metabolizes glycoconjugate? It is lysosome. So the right answer is choice B. Yes, dustbin of cell. A patient presents with multiple colonic polyps and has been diagnosed with colorectal cancer. There is a strong family history of HNPCC, hereditary non-polyposis colon cancer. Which DNA repair mechanism is most likely defective in this condition? Right. So HNPCC. In the name HNPCC, you see double C. It is caused by the defect of double M. Double C is caused by the defect of double M. Double M is mismatch repair. Do you understand this? Double C is caused by the defect of double M. It is mismatch repair defect. So the answer for this question is choice B. But let's learn about all repair mechanisms and associated disorders. Okay. There are 4 repair mechanisms. The first one is base excision repair. Right, base excision repair. Second is mismatch repair. Third is nucleotide excision repair. Fourth is double-stranded DNA break repair. Yeah, I am repeating this. What are the 4 repair mechanisms that can happen in a DNA? Base excision repair, mismatch repair, nucleotide excision repair, and double-stranded DNA break repair. Mismatch repair defect. There is no disorder, specific disorder, which is caused by base excision repair defect. So forget about it. Let's start from mismatch repair. Mismatch repair defect, just now I told you, causes HNPCC or Lynch syndrome. HNPCC or Lynch syndrome. And then nucleotide excision repair. In the name there is an X. Right? In the name there is an X. Defect causes X. What is X? Xeroderma pigmentosa. Nucleotide excision repair defect causes Xeroderma pigmentosa. The name itself is a clue. Excision has got an X. Okay. Now, double-stranded DNA break repair mechanism. I'm going to tell you few facts about this. Double-stranded DNA break happens in the presence of ionizing radiation. And whenever there is a double-stranded DNA break, repair can be done in 2 ways. One is non-homologous end joining. The other one is homologous DNA repair. Right? Whenever there is a double-stranded DNA break, repair can be done in 2 ways. One is non-homologous end joining. The other one is homologous DNA repair. The basic difference between the two is non-homologous end joining is the most common way by which double-stranded DNA break gets repaired, but it is a suboptimal way of repairing it. Right? It's a suboptimal way of repairing it because in this case, there is loss of some nucleotide sequences. In the case of non-homologous end joining, it is suboptimal because in this case, there is loss of some nucleotide sequences. Okay, so what are the 2 ways in which double-stranded DNA break can be repaired? One is non-homologous end joining. The other one is homologous DNA repair. Now, double-stranded DNA break repair defect causes 3 disorders. Double-stranded DNA break repair defect causes 3 disorders. Those 3 disorders can be remembered using a mnemonic ABF. Right? What does ABF stand for? Ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. Okay. Out of these 3, they can ask you which is caused by the defect of non-homologous end joining, which is caused by the defect of homologous DNA repair. The first one, ataxia telangiectasia, is caused by the defect of non-homologous end joining. Non-homologous end joining defect also causes severe combined immunodeficiency. So tell me, non-homologous end joining defect causes 2 disorders. One is ataxia telangiectasia, the other one is severe combined immunodeficiency. Homologous DNA repair defect. Homologous DNA repair defect causes Bloom's syndrome, Fanconi's anemia, and human breast and ovarian cancer. Is the voice breaking? Others? I don't think it's breaking. So homologous DNA repair defect causes Bloom's syndrome, Fanconi's anemia, and human breast and ovarian cancer. Okay. Okay, so that is all about DNA repair mechanism and the defects. I'm going to quickly help you recall all these facts. Mismatch repair defect, double M causes double C, hereditary non-polyposis colon cancer or Lynch syndrome. Okay, and then nucleotide excision repair defect causes xeroderma pigmentosa. Double-stranded DNA break repair defect causes ABF, ataxia telangiectasia, Bloom syndrome, Fanconi's anemia. And out of these, non-homologous end joining defect causes ataxia telangiectasia and severe combined immunodeficiency. Homologous DNA repair defect causes Bloom syndrome, Fanconi's anemia, and human breast and ovarian cancer. Okay. A breastfed infant presents with lethargy, hepatomegaly, and cataracts. Which of the following enzyme deficiencies is most likely responsible for this presentation? Okay, so first I'll tell you the answer. The answer is galactose 1-phosphate uridyl transferase defect, because this is called as classical galactosemia. Right, this is called as classical galactosemia. I'm choosing this as the right answer because I'm seeing cataract. I'm also seeing hepatomegaly. Okay, so let me tell you about all other choices. Okay, fructokinase defect. Fructokinase defect is called as essential fructose-urea. Fructokinase defect is called as essential fructose-urea. As the name indicates, essential because you don't see any features. No cataract, no hepatomegaly, no lethargy. The person is perfectly normal. Fructose is found in urine will be an accidental finding. Do you understand this? That's called as essential fructose-urea. No abnormality. Fructose is found in urine, which will be an accidental finding caused by the defect of fructokinase. Okay. Aldolase B defect. Please remember, aldolase B defect is called as hereditary fructose intolerance. Right, that's called as hereditary fructose intolerance. In this condition, what would you see? You would see lethargy, you would see jaundice, you would see hepatomegaly, hypoglycemia, okay, but no cataract. Fructose metabolism disorders do not present with cataract, okay. Galactokinase defect is called as galactosemia. But if galactosemia is because of galactokinase defect, then you see only cataract. Do you understand this? You see only cataract. You don't see hepatomegaly, you don't see jaundice, you don't see hypoglycemia. So, do you understand how we have arrived at the conclusion that it is choice B? First, because it's cataract, it is not fructose metabolism disorder. Because there is hepatomegaly, it is not galactokinase defect. It is classical galactosemia caused by the defect of galactose 1-phosphate uridyl transferase. Okay. Also remember, what is the description of this cataract? It is called as oil drop cataract. Yeah, the cataract that you see in galactosemia is called as oil drop cataract. Same topic, one more question which was asked previously. A 3-month-old baby was presented with severe hepatomegaly and cataract in both eyes. What is answer? The child appeared lethargic and hypotonia. Identify the enzyme that is involved. The enzyme is again galactose 1-phosphate uridyl transferase. Good. Which vitamin deficiency can cause lactic acidosis. Which vitamin deficiency can cause lactic acidosis? It is thiamine. Yeah, the answer is thiamine. So I am going to now tell you about thiamine and about alcohol metabolism continuously. Okay. So thiamine has been repeatedly asked in FMG. As far as thiamine is concerned, you need to know what are the thiamine dependent enzymes. Okay. So the thiamine dependent enzymes are number one, pyruvate dehydrogenase complex. This everybody should know. What is the function of pyruvate dehydrogenase complex? If you don't remember, please memorize it now. Function of pyruvate dehydrogenase complex is to convert pyruvate into acetyl-CoA. Why should you convert pyruvate into acetyl-CoA? Any glucose that enters into a cell, when it goes through glycolysis, it becomes 2-pyruvate. Okay. For further utilization of pyruvate, this pyruvate should enter into citric acid cycle. How does pyruvate enter into citric acid cycle? After pyruvate becomes acetyl-CoA, and that is done by pyruvate dehydrogenase complex. Please tell me, what if PDH complex does not convert pyruvate into acetyl-CoA? If this does not happen, then pyruvate would become lactate. Which enzyme converts pyruvate into lactate? It is lactate dehydrogenase. Do you understand this? Have you all memorized it? Pyruvate dehydrogenase converts pyruvate into acetyl-CoA so that it can enter into citric acid cycle. Lactate dehydrogenase converts pyruvate into lactate, that ends its metabolism. Okay. So PDH complex is dependent on thiamine. Whenever you include PDH complex, along with that in the list, you should also include alpha ketoglutarate dehydrogenase, because both these enzymes are similar in every possible way. So the next thiamine dependent enzyme is alpha ketoglutarate dehydrogenase. The third one is branch chain keto acid dehydrogenase of branch chain amino acid metabolism. You would have learned this already. Do you remember that defect of this enzyme causes maple syrup urine disease? Yeah, defect of this enzyme causes maple syrup urine disease. So that enzyme is also dependent on thiamine. The last thiamine dependent enzyme is transketolase. Okay, so can you all tell me what are the thiamine dependent enzymes? There are 4 thiamine dependent enzymes: pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, branch chain keto acid dehydrogenase, and transketolase. Okay, this is why whenever there is thiamine deficiency, pyruvate Gauri, what happened to you? Why are you crying? Whenever there is thiamine deficiency, PDH complex is inactive. When PDH complex is inactive, glucose cannot be utilized aerobically. Right? When PDH complex is inactive, glucose cannot be used aerobically. Neurons use glucose aerobically. Do you all know that? Neurons use glucose aerobically. So whenever there is thiamine deficiency, when PDH complex is inactive, neurons are not able to use glucose aerobically. Neuronal metabolism is affected. That causes neurological manifestations, which we call as dry beriberi. Don't you all know that thiamine deficiency causes dry beriberi? Yeah, what is dry beriberi? CNS involvement. Wet beriberi, CVS involvement. So why does thiamine deficiency affects nerves? It affects nerves because whenever there is thiamine deficiency, PDH complex is inactive, aerobic utilization of glucose cannot happen, neuronal metabolism is affected, so they present with neurological manifestations, which is called as dry beriberi. Not just this, when PDH complex is inactive, pyruvate becomes lactate. That causes lactic acidosis. And this lactic acidosis is responsible for wet beriberi. Yeah, lactic acidosis responsible for wet beriberi because lactic acid is a vasodilator. Do you understand this? It's a vasodilator. which causes hypotension and tachycardia. Right? It causes hypotension and tachycardia. That is wet beriberi. Okay, so that is about PDH complex being dependent on thiamine. Because branch chain keto acid dehydrogenase is dependent on thiamine, whenever you make a diagnosis of maple syrup urine disease, fix link all the teachers PDF for this week. Yeah, I will share the biochem PDF on the Telegram group. Yeah, you can get it from there. LRR, I mean, FMGE Resolve group, and it will be posted on the app. Okay. So, maple syrup urine disease, whenever you make a diagnosis of maple syrup urine disease, add the coenzyme. Maple syrup urine disease, of course, caused by the enzyme defect. Even if the enzyme is defective, you can add the coenzyme. What is its coenzyme? Thiamine. So, maple syrup urine disease responds to thiamine supplementation. Do you understand this? Maple syrup urine disease responds to thiamine supplementation. And because trans ketolase is dependent on thiamine, whenever you suspect thiamine deficiency, right? Whenever you suspect thiamine deficiency, you should estimate RBC trans ketolase activity. Do you understand this? Whenever you suspect thiamine deficiency, you should ask for RBC trans ketolase activity. Are you clear about this? So what are the clinical relevance of thiamine? I told you thiamine is necessary for PDH complex. That is why thiamine deficiency affects nerves, neurological manifestations, dry beriberi. Because thiamine is necessary for PDH complex, thiamine deficiency causes lactic acidosis, wet beriberi with hypotension and tachycardia. Because branch chain keto acid dehydrogenase is dependent on thiamine, maple syrup urine disease responds to thiamine supplementation. Because trans ketolase is dependent on thiamine, whenever you suspect thiamine deficiency, you ask for RBC trans ketolase activity. Apart from this, I want you to know two facts about thiamine. The first fact is thiamine is a sulfur containing vitamin. So if they ask you what are the sulfur containing vitamins, your answer should be thiamine and biotin. So what are the two sulfur containing vitamins? Thiamine and biotin. Second fact is thiamine is present in whole grains. Right? Thiamine is present in whole grains, particularly it is present in the allurin layer. Right? It's present in the allurin layer of grain. So polishing rice removes the allurin layer. Polished rice consumption can cause thiamine deficiency. To avoid thiamine deficiency, you have to parboil rice. When you parboil rice, allurin layer gets adsorbed onto the germ. So you're not losing thiamine. Do you understand this? Consumption of polished rice can cause thiamine deficiency. Parboiling rice retains thiamine. A family consumes a diet predominantly of rice and pulses, develop signs of muscle weakness and movement. Which of the following should be given for prophylaxis? What is the right answer, everybody? Yeah, rice and pulses, maybe polished rice, and then they are presenting with neurological manifestations. What is the right answer? Thiamine deficiency. A chronic alcoholic who consumes a non-vegetarian diet, again alcohol metabolism, right? Alcohol presence with hypoglycemia, all these questions have been repeatedly asked in FMG. So before you go for your exam, please have a quick look at alcohol metabolism and about chronic alcoholism. Okay, example is this MCQ. A chronic alcoholic who consumes a non-vegetarian diet presents with confusion, gait disturbance and eye movement abnormalities. So this is global confusion, ophthalmoplegia, ataxia. Global confusion, ophthalmoplegia, ataxia, GOVA is the short form for you to remember manifestations of Wernicke's encephalopathy. right? What is Wernicke's encephalopathy? That is acute thiamine deficiency, right? That is acute thiamine deficiency. So what is the right answer? The right answer is choice C, thiamine. Got it? Yeah. So now I'm going to tell you all that you need to know about alcohol metabolism. Okay. So how is alcohol metabolized? Alcohol is RCH2OH, right? Alcohol is RCH2OH, that is metabolized by alcohol dehydrogenase to form an aldehyde. And then an aldehyde dehydrogenase converts this aldehyde into an acid. Both these are dehydrogenases. You know, dehydrogenases remove hydrogen from the substrate. They give that hydrogen to their coenzyme, which is NAD, that gets converted to NADH. So just for metabolizing one molecule of alcohol to one molecule of acid, the person gets how many NADH? 2 NADH. So the metabolic status of a chronic alcoholic is that of high NADH-NAD ratio. Okay. When this NADH enters into electron transport chain, you know NADH becomes ATP. So there is a high ATP-ADP ratio. And every manifestation of a chronic alcoholism, right? Every manifestation of chronic alcoholism can be explained by these two factors. One is high NADH-NAD ratio. Ma'am, vegetarian diet, which vitamin? Vegetarian diet will cause B12 deficiency. Non-vegetarian diet will cause folate deficiency. Are you clear? Yeah. Let's come back to this. That's a distractor. Don't get distracted by that. Listen to this. Dr. Miss, instead of continuously asking the same question, okay? There is a reason why I'm not giving you an answer for that, okay? You will be able to find me if you want to on Telegram. It's not a secret, okay? But it will be posted on, on the app, and I'm sure it will be posted here also. The PDF I will share immediately. You will get it. Okay. So don't worry. Listen to this. So there is high NADH-NAD ratio and the other one is high ATP-ADP ratio. Okay. So what if there is high NADH-NAD ratio? Whenever there is high NADH-NAD ratio, all pyruvate get converted to lactate. Okay. All pyruvate get converted to lactate. And all oxaloacetate get converted to malate. Okay, whenever there is high NADH-NAD ratio, pyruvate would become lactate, oxaloacetate would become malate. So, a chronic alcoholic presents with lactic acidosis. You understand this? A chronic alcoholic presents with lactic acidosis. Not just that, there is low pyruvate and low oxaloacetate. Right? There is low pyruvate and low oxaloacetate. And pyruvate and oxaloacetate are the first two intermediates of gluconeogenesis. If these two intermediates of gluconeogenesis are deficient, gluconeogenesis will be impaired, and that causes hypoglycemia. Do you understand this? That causes hypoglycemia. So please remember, a chronic alcoholic is susceptible to repeated episodes of hypoglycemia. Why are they susceptible to repeated episodes of hypoglycemia? Listen to this carefully. It starts with high NADH-NAD ratio causing low pyruvate. High NADH-NAD ratio causing low pyruvate and low oxaloacetate, impairing gluconeogenesis. Right? This is the sequence of event which can explain why you see hypoglycemia in a chronic alcoholic. This was asked previously in FMG. Okay. Now, what happens when there is high ATP-ADP ratio? Whenever the energy status is high, the person never feels hungry. When the person does not feel hungry, the person keeps skipping meals. And you know, it's a mixed balanced diet which is supposed to provide a person with essential micronutrients. In this case, because the person keeps skipping meals, they are prone to develop multiple micronutrient deficiencies. Do you get it? So, That is why we call alcohol as a source of empty calorie. What do you mean by empty calorie? I'm not saying zero calorie. Empty calorie because excess energy without any micronutrient. Do you understand this? Excess energy without a micronutrient. Let me ask you this. Have you seen a gin? Yeah, gin fortified with vitamin D. Say yes or no. Gin fortified with vitamin D. No. Have you seen a beer fortified with vitamin A? No, right? Yes. So because alcohol cannot be fortified. You will never see an alcohol which is fortified with vitamin D or thiamine. Alcohol can never be fortified. That is why alcohol is a source of empty calorie. Okay, so excess energy without any micronutrients. And that is why they are prone to develop multiple micronutrient deficiencies. And of all the micronutrients, the most common micronutrient to become deficient in a chronic alcoholic is thiamine. Why is thiamine deficiency common? The first reason I told you just now, alcohol is a source of what calorie? Empty calorie. The person keeps skipping meals, so they're prone to develop essential micronutrient deficiencies. The first reason. The second reason is alcohol interferes with thiamine absorption. Okay, alcohol interferes with thiamine absorption. So even if the person pops in thiamine tablets, as long as the person consumes alcohol, the thiamine cannot be absorbed. Okay. The third reason is alcohol interferes with magnesium absorption. It also interferes with magnesium absorption. That is why many chronic alcoholics are hypomagnesemic. Okay. But what is the relevance of hypomagnesemia in thiamine deficiency? The relevance is active form of thiamine is thiamine pyrophosphate. You know that, right? Active form of thiamine is thiamine pyrophosphate. And the enzyme which can convert thiamine to thiamine pyrophosphate is thiamine kinase. And this thiamine kinase is dependent on magnesium. So whenever there is hypomagnesemia, active form of thiamine cannot be synthesized. So can you all tell me what are the three reasons? Yeah, what are the three reasons because of which there is thiamine deficiency in a chronic alcoholic? First reason is alcohol is a source of empty calorie. Alcohol interferes with thiamine absorption. Alcohol interferes with magnesium absorption. Okay. And whenever there is thiamine deficiency, you know that nerves get affected the most. I already told you why. What is the reason I gave you? The reason is nerves use glucose aerobically, and for aerobic utilization of glucose, nerves need PDH complex. That PDH complex is dependent on thiamine. So whenever there is thiamine deficiency, aerobic utilization of glucose cannot happen. Neuronal metabolism is affected. That is why you see neurological manifestations. Okay. And whenever nerves get affected in alcoholism, whenever nerves get affected in thiamine deficiency in a chronic alcoholic, it can take two forms. The first one is acute thiamine deficiency. The other one is chronic thiamine deficiency. Acute thiamine deficiency is otherwise called as Wernicke's encephalopathy. Okay, acute thiamine deficiency is otherwise called as Wernicke's encephalopathy. Let me give you a practical example wherein you might induce Wernicke's encephalopathy in your patient, which you call as iatrogenic Wernicke's encephalopathy. I'm going to tell you that scenario. The scenario is you are in a casualty. Okay, to this casualty, a group of relatives are bringing a patient because of unconsciousness. Okay, the moment you see an unconscious patient, you know that the most common cause of unconsciousness is hypoglycemia. So to find out if it's hypoglycemia, using a glucometer, you're checking the pH. Using a glucometer, you're checking the glucose. Glucose value is say 55 milligram per deciliter, which is frank hypoglycemia. So now one step is over. You made the diagnosis. Your diagnosis is hypoglycemia induced unconsciousness. You have started treating the patient. You know, hypoglycemia needs to be treated with dextrose, right? Hypoglycemia needs to be treated with dextrose. So you're starting dextrose infusion, right? What is dextrose? Dextrose is D-glucose dissolved in water. And when you start that infusion, glucose enters into all cells. Okay, glucose is metabolized within these cells and glucose would become 2-pyruvate. For further metabolism of pyruvate, these enzyme needs PDH complex. That complex is dependent on thiamine. Okay, so in this entire history, what you failed to do is you did not elicit personal history of your patient. Had you asked for personal history, the relative would have told you that this person is a chronic alcoholic. Had you known that this person is a chronic alcoholic, you should have remembered that alcoholic would present with thiamine deficiency. So what you should have done is you should have started first thiamine injection and then you should have started dextrose infusion. You did not do any of this. You straight away went to dextrose infusion. Glucose has entered into the cell. That glucose has increased the utilization of thiamine. So all along, this person was in a subtle thiamine deficiency status, which you made suddenly overt by starting this dextrose infusion. That sudden acute thiamine deficiency status is called as Wernicke's encephalopathy. Do you understand this? So if your aim is to avoid Wernicke's encephalopathy, always ask for personal history. And if you get to know that your patient is a chronic alcoholic, don't directly start dextrose. First, give him or her thiamine injection and then start dextrose infusion. You get it? First give him thiamine injection and then start dextrose infusion. Otherwise, there is acute thiamine deficiency or Wernicke's encephalopathy. What is the mnemonic I gave you? Please remember, what is the mnemonic for Wernicke's encephalopathy? GOVA. What does GOVA stand for? Global confusion, ophthalmoplegia and ataxia. Right? Global confusion, ophthalmoplegia and ataxia. Okay, this is a reversible stage. And at this stage, if you don't respond, and if the person is susceptible and if the person is subjected to a very long episode of acute thiamine deficiency, for a very long time, the person is a chronic alcoholic thiamine deficient. That causes chronic thiamine deficiency. And this chronic thiamine deficiency is called as Korsakoff syndrome. Right? What is it called as? Korsakoff syndrome. And what do you see in Korsakoff syndrome? In Wernicke's encephalopathy, it is only a confusion. In Korsakoff syndrome, it is amnesia, total memory loss. So they present with retrograde amnesia. They present with anterograde amnesia. Confabulation. Right? What is confabulation? The person starts fabricating stories. We call this as a honest lie. Right? This is called as honest lie because a person does not even know that the person is lying. Only because there is a memory gap, the person fills the memory gap by fabricating stories. For example, if you are showing a person, a chronic alcoholic, his own daughter, and you're asking him, who is that? He would say, this is my sister's daughter. Not because the person wants to evade responsibility, but because a child looks very familiar to him. But he has forgotten the fact that he has a daughter. So to fill up that memory gap, he says, this is my sister's daughter. He honestly believes that that is his sister's daughter. That's called as honest lie or confabulation. And they present with sensory agnosia. Okay, so these are the features of chronic thiamine deficiency or Korsakoff syndrome. This is an irreversible stage. Do you understand this? Korsakoff syndrome is an irreversible stage wherein imaging detects cerebellar atrophy. Imaging detects cerebellar atrophy. It detects mammillary body atrophy. So here it is not just the metabolism that is affected. Nerves are affected structurally. That is why it is irreversible. Okay, so that's about thiamine deficiency in a chronic alcoholic, which can present as Wernicke's encephalopathy or it can present as Korsakoff syndrome. Not just thiamine deficiency, any micronutrient deficiency can be seen in a chronic alcoholic. I've seen chronic alcoholic with macrocytic anemia due to folate deficiency, due to B12 deficiency. I've seen chronic alcoholic with Bitot spots, vitamin A deficiency. I've seen chronic alcoholic with 3Ds of pellagra. All because alcohol being a source of empty calorie, any micronutrient deficiency is possible, but the most common is thiamine deficiency. Okay. And then they present with fatty liver. Fatty liver is because of anabolism. Why anabolism? Because of high ATP ADP ratio. The energy status is high, so the person gains weight. Don't you know beer belly? Yeah, beer belly. So it is a source of empty calorie, high calorie without micronutrient. Anabolism happens everywhere. That anabolism happens in liver. Liver synthesizes and deposits fat, causing fatty liver changes. Okay, they present with hyperuricemia. Don't you? Okay, you don't worry about what others are speaking. You just focus on what I'm saying. I know it can be a distraction. It's distracting me also. But let's focus here, right? So alcoholism and hyperuricemia. We know that they present with hyperuricemia. That is why we say an episode of gouty arthritis is precipitated by binge drinking. Do you remember that? Gouty arthritis is precipitated by a binge drinking episode. So, you know, drinking alcohol causes hyperuricemia. Why does alcohol cause hyperuricemia? Because alcohol is an enzyme inducer. Right? It's an enzyme inducer. It induces enzymes involved in purine breakdown. So whenever there is excess purine breakdown, that causes uric acid and that causes hyperuricemia. So are you clear about chronic alcoholism and the impact? Yeah. So what is the answer here? This we know, guava thiamine deficiency. I told you, right? This was also asked. A patient with a history of strenuous exercise skipped a meal and later consumed alcohol at a party. Alcohol inhibits which of the following biochemical processes, potentially leading to hypoglycemia? What is your answer? The answer is gluconeogenesis. Very good. Why gluconeogenesis? What did I tell you? High NADH causes low pyruvate and low lactate, and that would impact gluconeogenesis. Similar question or almost the same question the previous year. Okay. The patient had a history of strenuous exercise but forgot to take his meal and later had alcohol in a party. Which of the following processes is inhibited by alcohol? What is the right answer again? Again, gluconeogenesis. This is why there are many repeat questions in FMG. So please work out all previous year questions. Okay. A 45-year-old chronic alcoholic presents with anxiety, tremors, and hallucination. His last drinking episode was 48 hours back. What is the most likely diagnosis? Yeah, 48 hours alcohol withdrawal followed by tremors. What is it? Delirium tremens. Yeah, it is one of the features of alcohol withdrawal. It is delirium tremens. Very good. The same question or similar question. A chronic alcoholic patient who's used to taking arak or local alcohol for the last 25 years suddenly presented with agitation and confusion. There were gait abnormalities. On inquiry, the person gave a history of alcohol withdrawal for 3 days. Between 2 and 10 days after alcohol withdrawal is when you can see delirium tremens. This is not thiamine deficiency dura mater. Yeah, between 2 and 10 days, because had it been thiamine deficiency, yes, they could have presented with confusion, but you should have seen other features of Wernicke's encephalopathy like ophthalmoplegia. Do you see that here? You don't see it. right? So alcohol withdrawal and then confusion, that is delirium tremens. Answer is choice B. No C, it is B. A 50-year-old man who is a chronic alcoholic was presented with complaints of confusion, tingling sensation, neurological manifestation. His history revealed Polish rice is his main diet. So what is the right answer? This is beriberi. Classical, right? Good. This is beriberi. So this will be the last topic for today. Yeah. So I'll tell you about blood collection tubes. Which color-coded collection tube is used for coagulation studies? For coagulation studies, it's a blue-topped tube. Right? It's a blue top tube which has 3.2% sodium citrate. It has 3.2% sodium citrate. That's a blue top tube that is used for coagulation assays. Genetics, I told you, Dr. Miss. Did you miss it? So the answer is choice A. But I'm going to tell you about all blood collection tubes now. Okay. So the first one that you should see is a red top tube. What is a mnemonic for red top tube? RSS. What does RSS stand for? R stands for red, S stands for silica, and the next S stands for serum. Okay, the next S stands for serum because silica is a clot activator. Do you understand this? What is silica? Silica is a clot activator. After clot gets stabilized, what separates above is called as serum. Are you all clear? So what are the facts that you need, that you know about red top tube? The mnemonic is RSS, red is R, and then silica, serum. Silica is a clot activator. And if you're asking me, what do I use red top tube for? Red top tube is used for biochemical analysis. What do you mean by biochemical analysis? For you to estimate renal function test, liver function test, pancreatic function test, cardiac function test, thyroid function test, or any hormone assay, electrolyte estimation, right? So most of the tests which are done in biochemistry lab, which sample will we need? We need a sample in a red top tube, which is a serum sample. Okay. Now, have you seen a gray top tube? Yeah, gray top tube, G for G. Gray top tube is for glucose estimation. Do you understand this? It's for glucose estimation. And the additive that is in a gray top tube is sodium fluoride and potassium oxalate. What does it have? It has sodium fluoride and potassium oxalate. What does fluoride do? Fluoride inhibits enolase. Okay. So fluoride inhibits enolase of RBCs. It inhibits glycolysis in RBCs so that RBCs do not use glucose after sample collection. What will happen if you allow RBCs to use glucose after sample collection? And then if you estimate, it is like you estimating leftover glucose. That causes false low values. We don't want to get false low values. That is why we collect blood sample in a tube with sodium fluoride and potassium oxalate. Fluoride inhibits enolase of RBC so that RBCs don't use glucose, so that you get a true value. Okay, the same gray top tube is not only used for glucose estimation, it is also used for lactate estimation. Why for lactate estimation? Otherwise, if there is no enolase, if there is no fluoride, if RBCs undergo glycolysis, RBCs would release lactate, causing false elevation of lactate. I don't want that. That is why for glucose estimation, for lactate estimation, I collect blood sample in a gray top tube which has sodium fluoride and potassium oxalate. Fluoride inhibits enolase of RBCs. Okay, the same tube is also used for blood alcohol estimation. It is also used for blood alcohol estimation. If you're all wondering, what about the breath analyzer that they do in the on the roads, right? So that breath analyzer is like a preventive measure wherein they are checking if the person is drunk. If the person is found to be drunk, the person is asked to not drive. So you're avoiding road traffic accident. What if road traffic accident has already happened and you're trying to solve the case? You're trying to find out if the driver was drunk when the accident happened, for which breath analyzer reports are not acceptable. You need to collect blood sample from the driver. In that blood sample, you have to estimate alcohol. For that blood alcohol estimation, collect blood sample in a gray top tube, because this tube has got fluoride. Fluoride inhibits enolase of not only RBCs, it also inhibits enolase of microorganisms that are present in the sample. If you don't inhibit enolase of microorganisms use glucose, convert glucose into alcohol. That causes false elevation of alcohol. That should not happen. So which tube, all of you answer, which tube is used for blood alcohol estimation? The tube that is used for blood alcohol estimation is a gray topped tube. But in FMG, they asked you a complex question, right? The question was, what is the ideal substance? Right? What is the question? What is the ideal substance that is used for measuring blood alcohol? The ideal substance is sodium fluoride and potassium dichromate. Right? What is the ideal substance used for measuring blood alcohol concentration? It is sodium fluoride and potassium dichromate. But manufacturers of blood collection tubes do not manufacture this tube. Right? What is the probability that somebody will go and buy this tube? Right? Road traffic accident and then the number of samples, right? So we don't manufacture this tube, and that is why we are using gray top tube. But the question was ideal substance. The ideal substance for blood alcohol estimation is sodium fluoride and potassium dichromate. So tell me, what are the uses of gray topped tube? Gray top tube is used for glucose, lactate and alcohol measurement. Okay. This one, everybody must have used, right? Lavender top tube. What do you see in a lavender top tube? It has got K2 EDTA or K3 EDTA. Right? It has got K2 EDTA or K3 EDTA. This is used for complete blood count. Do you understand this? Used for complete blood count. Just think, okay? What would have happened if I had collected blood sample in a red top tube? Okay, when there is a clot activator. It allows the clot to get stabilized. And then I'm sending into the pathology lab, asking for complete blood count. Will they be able to do it? They cannot do it, because in a red top tube, the clot is already formed. Within the clot, all cells are trapped. When cells are trapped, can you measure RBC count? Can you measure WBC count? Can you measure platelet count? No. So clot should not happen. That is why I add an anticoagulant. The anticoagulant that I add is K2 EDTA or K3 EDTA. In this presence, there is no clotting, and in the lab, the sample is received, the sample is mixed well, and then it is fed into the analyzer. The analyzer then segregates all cells, measures individual cell, and gives you the report. So, what do you use EDTA tube for? EDTA tube is used in pathology for complete blood count when you want a whole blood sample. Okay. The same is also used for HbA1c measurement. HbA1c is glycated hemoglobin. Just because I said to biochemistry lab send sample in a red top tube, if you're sending a sample in a red top tube and if you're asking for HbA1c, I will not be able to analyze it, because in a red top tube, all RBCs are trapped in the clot. Right? All RBCs are trapped in the clot. Without RBCs, no hemoglobin. Without hemoglobin, no glycated hemoglobin. So if you are sending a sample for HbA1c estimation to a biochemistry lab, collect it in a tube with EDTA. What do we do in the lab? In the lab, when we receive the sample, we add a hemolysate. That hemolysate lyses RBCs. Hemoglobin comes out, we measure it, we give the report. Do you get it? So for HbA1c also it is EDTA tube. And whenever you have to analyze labile parameters like parathormone, ACTH and ammonia, whenever you have to estimate labile parameters like parathormone, ACTH and ammonia, you should estimate, you should collect blood sample in a lavender top tube, because the EDTA chelates calcium, and without calcium, proteases are inactive. Without proteases, these labile parameters are not degraded. Do you understand this? They are not degraded. So tell me, what are the uses of EDTA tube? All of you answer. EDTA tube is used for complete blood count in pathology, in biochemistry for HbA1c, for parathormone, ACTH and ammonia estimation. For all these purposes, it is EDTA tube. Good. This was the question about, right? Blue top tube. So blue top tube has got 3.2% sodium citrate. Blue top tube has got 3.2% sodium citrate. C for C, it is used for coagulation assays. Right, it's used for coagulation assays. What do you mean by coagulation assays? Prothrombin time, activated partial thromboplastin time, fibrinogen assays, factor assays. Right, prothrombin time, activated partial thromboplastin time, fibrinogen, factor assays. For all these coagulation assays, it's citrated tube, 3.2% sodium citrate, which is blue topped tube. Okay. And then green. What do you use this green top tube for? Green top tube has got heparin. Okay. So the moment I say heparin, all students would say it is used for ABG analysis. Yeah. So please remember, this is not used for ABG analysis. For ABG analysis, do you remember collecting blood sample in a syringe? For ABG analysis, you have to collect a blood sample in a syringe, because it has to be an anaerobic sample collection. The sample should not be exposed to atmospheric air. For ABG, the sample should not be exposed to atmospheric air. If you're collecting it in a tube, the tube has got air. Okay, so that will cause false values of PO2, PCO2. For ABG, it is not a tube, it's a syringe. So what you use is heparinized tube for. Heparinized tube is used whenever you need to estimate stat biochemical analysis. Right? What do you mean by stat biochemical analysis? Whenever quick analysis has to be done. For example, I want to estimate electrolytes. Electrolytes in a critically ill patient. Okay. I cannot just collect blood sample in a red top tube. I cannot just write in the request form urgent and send it. Right. Just because you have written urgent in the report, in the lab, I cannot allow the clot to quickly form. The clot will take its own time to clot. Right. And only after that I can centrifuge, only after that I can analyze. So whenever you want quick analysis to be done in biochemistry, don't collect it in a red top tube, collect it in a heparinized tube. If it's heparinized tube in the lab, as soon as I receive the sample, I centrifuge it, I analyze it, I give you the report. So stat or quick biochemical analysis for molecular diagnostics and for cytogenetics. Okay, molecular diagnostics and cytogenetics. So for all these purposes, whenever DNA has to be extracted or whenever RNA has to be extracted, it has to be collected in a green topped tube. So tell me, what do you use this green top tube for? Green top tube is used for stat biochemical analysis, molecular diagnostics. I will tell you about order of draw. Please wait. Sarpak May. Okay, please wait. So this is what green top tube is used for. Okay. And then the last one, yellow top tube. Okay. So in this yellow top tube, do you see a gel at the bottom? Yeah, there is a gel at the bottom and then it is sprayed with a clot activator. Okay. So what do you call this tube as? You call this tube as gel and clot activator tube. This is called as gel and clot activated tube. When do you use this gel and clot activated tube? How do you use this tube? In this tube, you first collect blood sample. When you collect blood sample, the sample lies above the gel and then you centrifuge the sample. When you centrifuge the sample, the gel ascends up and it acts like a mechanical barrier. When you centrifuge it, the gel ascends up and it acts like a mechanical barrier between cells at the bottom and serum on top. Yeah, between cells at the bottom and serum on top. So what is the use of gel and clot activated tube? Anything happens in the cell layer does not affect the serum because this acts like a mechanical barrier. And this is used whenever the sample has to be transported or whenever the sample has to be stored for a prolonged period of time. Do you understand this? So for example, there is a reference lab in Delhi. Okay, and the sample is collected somewhere in the south. Okay, so from here the sample has to be transported to Delhi. That takes a longer time. In that case, if I collect blood sample in an ordinary red top tube, eventually the cell undergoes lysis and the intracellular fluid of RBCs would contaminate the serum. So the values that I get will be affected. I don't want this to happen. I want a mechanical barrier. That is when I use a gel top tube. So yellow top tube is a gel and clot activated tube which needs to be used whenever the sample has to be stored or whenever the sample has to be transported for a prolonged period of time. Got it? Yeah. So a quick recap, all of you, a quick recap starting from red. So tell me, what is the mnemonic I gave for red top tube? RSS, red silica serum. Silica is a clot activator. It is used for biochemistry analysis. Okay. And then gray top tube. What is this gray top tube used for? G for G. It is used for glucose estimation. Not only for glucose, it is used for lactate estimation and for alcohol measurement. But what is the ideal substance used for alcohol measurement? Sodium fluoride and potassium dichromate. For ESR, we now use only lavender top tube or EDTA tube. Because these days we are not using the Wintrobe's method or Westergren's method. These days it's an automated ESR analyzer. Right, it's an automated ESR analyzer. That analyzer uses the same EDTA tube that is used for complete blood count. That is why I did not tell you about the black topped tube. What is the black top tube? Black top tube has got 3.8% sodium citrate. Where do you see 3.2% sodium citrate? The blue top tube for coagulation assay. Black top tube has got 3.8% sodium citrate that is used for ESR, and this is used for ESR only when it is Westergren's method or Wintrobe's method, not for automated ESR analyzer. Do you all understand this? Yeah. So that is about gray. And then we saw about EDTA. Please tell me the use of EDTA tube. Complete blood count, HbA1c, parathormone, ACTH and ammonia. Okay. And then blue top tube. Blue top tube is citrate, right? So citrate has got 3.2% sodium citrate, which is used for coagulation assays. Green, heparinized tube. Heparinized tube is used for quick biochemical analysis, and this is also used for molecular diagnostics and cytogenetics. And finally, yellow top tube, gel and clot activated tube. What do we use this for? Whenever sample has to be transported or sample has to be stored. Okay. So now about order of draw, that is what you people kept asking. Order of draw, what you should collect first is, you should collect blood sample in a tube first. If this sample is used for measuring an analyte, which is very sensitive to contamination, that should be collected first, right? And you should collect sample in a tube last. If this tube has got an additive, and if that additive is notorious to cause contamination, that should be collected at last. Isn't that logical? Right? What does order of draw tell you? The order of draw tells you this is the order in which blood has to be collected. And logically, you should collect blood sample in a tube, which is used for measuring an analyte, or which is used for a purpose wherein the analyte is sensitive to contamination. When will you collect last? When you know that the tube has got an additive and that additive is notorious to cause contamination, that should be collected at last. Okay, so that way you should collect blood sample first in culture bottles. Obviously, right? You should first collect blood sample in culture bottle first. That should be followed by citrated tube. Culture bottle should be followed by a blue top tube, a citrated tube, because coagulation assays are very sensitive to contamination. After blue, it is traffic light. In traffic light, do you remember seeing a red light followed by yellow light followed by a green light? Right? So it is red, yellow and green. After green, it is lavender or EDTA tube. And the last one should be the grey topped tube, because grey top tube has got fluoride, and fluoride is notorious to cause contamination. Do you all understand this? So tell me the sequence. The first one to be collected is a culture bottle, followed by citrated tube or blue top tube, and then the traffic light red, yellow, green, followed by lavender top tube. Finally, it is a grey top tube. Okay. So what is answer? Which color coded collection tube is used for coagulation studies? It is blue. This is what I told you, this is the last question for tonight. Which of the following substances is used for sample collection in tube for blood alcohol concentration measurement? Blood alcohol concentration, it is sodium fluoride and potassium dichromate. Okay. So thanks everybody. My best wishes. And apart from this, try to watch image-based questions that is available on YouTube. Okay, and try to watch the previous LRR for FMG as well. Okay, if you do these three, it will cover all topics. Okay, yeah. Good night. Thanks, everybody. Thank you.